Good morning, everyone, and welcome to the House Committee on Health, Human Services, and Elderly Affairs. We have several bills scheduled for today's hearings. Before we do those, however, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be heard this morning is Senate Bill 545 FN. And for the purposes of introduction, I'll recognize the prime sponsor who is already in place. Good morning, Senator Rosenwald.
Good morning, Mr. Chair and committee members. For the record, I'm Senator Cindy Rosenwald. I represent District 13, which is most of Nashua. And I'm happy to be here this morning to introduce Senate Bill 545, the Help for Low-Income Seniors Act of 2026. As amended by the Senate, this bill clarifies that New Hampshire will continue to facilitate eligible Medicare beneficiaries' enrollment in the low-income drug subsidies. Congress's H.R. 1 of last year introduced some confusion as to whether states that were already doing this work had to stop for 10 years. So Senate Bill 545 just clarifies that we will still do what we've been doing all along for 38,000 low-income older Granite Staters. Since the low-income drug subsidy is 100% federally funded, this bill has no fiscal impact to the state. So if you saw the fiscal note from the original bill, you can just ignore that. We eliminated the first section of the bill. I think it was the first section, the one that caused the spending is now not there. So Mr. Chairman and committee members, I really can't think of anything sadder than someone who turned 65 has paid Medicare taxes on every dollar they've ever earned, but they're so low income they can't afford to pay their Medicare Part D premiums, copays, deductibles. So they can't afford medical treatment just as they're most likely to need it. I hope the committee will agree that Senate Bill 545 is a reasonable approach to a serious problem. Thank you, and I'm happy to answer questions. There are also other people here who may be able to better answer technical questions.
Thank you, Senator. Yeah, looking at the fiscal note, it was pretty substantial.
It's
2.3
gone.
million. It's good that it is gone.
And I have an LBA fiscal impact worksheet basically saying it's gone. So that the Senate amendment took all the spending out, the state spending.
Thank you. Any questions for Representative Polozov?
Thank you, Mr. Chair, and thank you for taking my question. So you gave us some recent developments in this program. Could you tell historically when this eligibility was created?
When the MSP program was?
Yes.
Well, Director Lippman from Medicaid is here, and even though Medicare is a federal program, the MSPs are managed by the Medicaid Bureau, but I will say that in my first term 22 years ago, I remember there was discussion in the health committee about the Quimbies and the Slimbies. And I didn't know at the time what they are, but those are the individual Medicare beneficiaries that are enrolled, and some of them are below 100% of the federal poverty line, and some are up to 135% of the federal poverty limit.
Representative McLean.
Thank you very much, and thank you for taking my question. So, you mentioned that there was some confusion coming out of the federal government and that there was a requirement for a 10-year suspension. And I'm not exactly sure how that would play out, if you maybe have some details. But so if we were not to have this legislation, then given that confusion, does that mean that our access to those federal dollars will be in jeopardy? I'm just trying to understand some of the details of that.
I think there's a possibility that they could be. Our interpretation at the department has been that we don't have to have the 10-year moratorium because we were already automatically enrolling beneficiaries. This really is a belt and suspenders bill.
Anyone else? Seeing no one else? Okay,
Thank you very much.
Thank you. Also signed up to speak is Judith Jones from New Futures.
Good morning, Mr. Chair. Good morning, committee members. And I'm so happy to be here to speak in favor of this bill as amended. My name is Judith Jones. I'm the Healthy Aging Policy Director at New Futures, which is a nonprofit, nonpartisan group that advances positive policy in New Hampshire. But I'm also here on behalf of the New Hampshire Alliance for Healthy Aging, and that's a group that represents 500 individual and stakeholder groups to promote healthy aging in New Hampshire. So this bill helps older adults, especially those struggling with prescription drug costs. And what it does is maintain the strong connection between two benefit programs. And what you've heard referenced by Senator Rosenwald is these two programs. One is called MSP, or the Medicare Savings Program, and another federal program called LIS, Low Income Subsidy, which is a Medicare Part D program. So if we look at these two programs, the MSP programs, which I tried looking quickly how long they've been around. I can say as long as I've been doing Medicaid work in New Hampshire, they've been around. And they're key programs that pay for gaps in Medicare coverage. And what often elders find out when they go on Medicare, they think that their expenses for healthcare are going to be covered. And what they learn, unfortunately, is that Medicare has so many gaps. So these New Hampshire Medicaid, Medicare savings programs help pay for the gaps in Medicare. And then what we have also is a federal program, purely federal. It's called LIS, and it helps pay for federal Part D prescription drug coverage. So while many folks are aware of the MSP programs and what they do, one part of MSP eligibility is that if you're eligible for MSP, you're also eligible for this federal prescription drug coverage under LIS. So what would happen is if the department makes someone eligible for an MSP program, they would automatically be eligible for an LIS program. And keeping the connection between those two programs strong is so important to New Hampshire when we look at what does the LIS program do for New Hampshire. So if we look at what LIS does in New Hampshire, the department reports that there are 38,000 individuals right now on that program. And if we look at figures from CMS, what they estimate is that annually per participant, roughly $5,700 are paid per individual. So if you look at that cost, 38,000 times 7,500, what we have is a benefit of over $216 million to Granite Staters. So why the need to have this clarification or this belt and suspenders? What we know about these LIS programs, studies show they're underutilized. that so many people are eligible for them and don't access these programs. And what studies show, the reason for that is the application can be difficult, and a lot of people just don't know about the programs. So by strengthening and ensuring that tie between MSP eligibility and LIS eligibility, and automatic enrollment in LIS if you're on MSP, you give the best chance of high enrollment in LIS in New Hampshire. And any bill that uses 100% federal funds, that is just helping to make sure we keep the highest number of individuals enrolled in LIS, will surely help older adults who we see struggling with prescription drug costs, often struggling to meet financial needs. So this bill strengthens the tie between these two programs, and that strong tie will help enrollment it's close to bringing dollars back into the pockets of Granite Staters. So based on how the two public benefits programs work, based on we're looking at federal money, based on the need to make sure that connection stays strong, I urge the committee to support the legislation.
Thank you. Any questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. We heard that there were some changes in federal HR 1 bill. So could you speak a little bit to it, what specifically was brought by HR 1?
Yes, so if what we'll stick to with HR 1 is how that bill impacted the Medicare savings programs. So in 2023, federal Congress adopted a lot of provisions to streamline eligibility into the MSP programs. So there were about 5 provisions. These were all adopted. So it was just a whole number of different provisions to let's get these programs easier to get on. And what happened under the federal bill is some of these streamlinings were delayed 10 years. Others were let to pass through. Some were allowed to pass through if the state was doing it. And all this is subject, of course, to CMS approval. So it's fair to say, with a lot of improvements that were headed to happen, with some being pulled back and others not being pulled back, it did create some confusion among national advocates about how we could advocate and what we could actually advocate for. And this is one path that looks like we're allowed to proceed under federal law, and it gives advocates one way to help their state beneficiaries.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So the prime sponsor mentioned that this basically is allowing us to continue to do what we've already done. But the bill does say that it's subject to CMS approval. And when I look at the methodology, it does say that we're removing asset limits, which is going to allow us to bring on an additional 2,000 individuals. So that is a little bit of a difference. So when you're talking about the impact of the CMS approval, is that because of the 2,000 people? Is that kind of where the danger zone is? And is there any jeopardy from CMS in doing this? Or just kind of talk to that.
Yeah, oh, surely. So I think that any parts of the bill that would change eligibility for MSPs are gone.
Okay.
So what we see is anything that would change an eligibility limit for someone on the MSPs has been removed from the bill. I think the language in the bill that says subject to CMS approval is probably a wise move, knowing that you always want anything that New Hampshire does to be subject to CMS approval.
Okay. So quick follow-up, Mr. Chair.
Sure, follow up.
So just so then to be clear, because I'm just reading through the methodology in the fiscal note, which the prime sponsor said that is kind of, so that means then that the asset limits are gone and it truly is, we're not looking at these extra 2,000 people, it is just a status quo going forward.
With regard to financial eligibility, it certainly is a status quo, and that was the part of the bill that resulted in a hit to the budget that was just not the time for.
Thank you very much.
Thank you.
Anyone else? Seeing no one else, thank you. Also signed up to speak is Henry Lippman from the Department of Health and Human Services.
Good morning. For the record, Henry Lippman, State's Medicaid Director. This program was established in 2003 federally, and I think HR 1 has been clarified. I had worked this week with, actually Friday and Monday, with Kevin Ripple on revised fiscal notes, so you should be seeing that. What you will see is that we went back and did a 5-year analysis of what we were allocated from the federal government and what we spent. We've been well below that limit, and we're continuing to be funded. I'll just say this about this program, and as much as it helps beneficiaries, it also helps the state budget if you think about it, because the obvious is all federal funds, right? But the second one is if people don't get the medications they need and end up institutionalized as a result of that, they generally end up on Medicaid. And so I think in terms of, it's, I think, a wise thing to continue to do. The people that are deemed eligible from an income standpoint, we get a file from Social Security. The people do have to apply for the benefit. So I think it's a very good program for the people, very important to maintain. And I think it also has favorable budget implications for the state. And we all know we're up for another challenge in terms of budget. And so I think this is a very good program for beneficiaries and the state.
Thank you. Any questions for Mr. Lippman? Did have one, you said there's a revised fiscal note?
Yes, I think Kevin told me it would be a bit out today, but obviously not in time for this meeting.
Do you know what it says, or
Yeah, and
any
I think,
state funds involved at all? Or?
no, this is 100% federal. There is a cap that the state receives. We've been well under the cap, and then nationally there's a dollar value that then is for states if they were running into an issue that gets reallocated among the states. So we've never exceeded the cap. I think we're over 7 million on our cap. We've spent 4.2 in 25, and so I think very comfortable saying that we have an allowance that protects the state.
Great, thank you. We'll find call for questions. Okay, thank you very much.
Thank you.
Okay, no one else has signed up to testify on SB 545 FN. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on SB 545 FN. Next hearing will be at 9:30 on SB 468. We will be in recess until that time. Okay, welcome back. I'd like to reconvene the hearings for the day and open the hearing for SB 468. Senator Howard Pearl is the prime sponsor, but a co-sponsor is Senator Tara Reardon, and she is here to introduce the bill. Good morning.
To introduce SB 468 relative to enabling alternative treatment centers to operate greenhouse cultivation rotation. This is a really simple bill. It lets alternative treatment centers cultivate their product with a greenhouse, one greenhouse per operation. It saves energy. It reduces the energy these treatment centers have to draw to the grid, ultimately lowering costs for 17,000 therapeutic cannabis patients in the state of New Hampshire. Let's just be clear about who therapeutic cannabis patients are. They're elderly Granite Staters with Parkinson's disease. They're cancer patients seeking comfort as their body fails them. And they're Granite Staters facing lifelong disability and mobility issues. In other words, this bipartisan bill isn't asking you to make pot a little cheaper for anybody. It's asking you to make sick Granite Staters' quality of life better at a lower
Senator, could you put your microphone on? There you go.
You want me to start over?
No, that's fine. That's fine.
Thank you. So this bill, we believe, is just common sense. It's a widely popular concept. It passed through the Senate unanimously in the committee and on a voice vote on the floor. So let's do the right thing for Granite Staters and move this bill along, pass this bill. I'd be happy to take any questions, but there are experts coming after me who are probably better equipped to do that.
Okay. Any questions for Senator Reardon? Seeing none? Okay,
Thank
you. Also signed up to speak is former Representative Jerry Knirk. Or did you want to? Oh, okay. Sue Hamolo? Okay. How do you pronounce your name? Hamola?
Hamola, yes, sir.
Okay.
For the record, Sue Hamola from Hollis. Thank you for the opportunity. Thank you, Dr. Knirk. I just wanted to quickly add a couple bits of information. This bill actually was voted interim study out of committee, and on the floor, the Senate floor, I believe, if I'm understanding the docket correctly, then that was overturned and not to pass was proposed and voted on a voice vote. Just so you understand of that. One of the concerns that SAM New Hampshire has about this bill is that the therapeutic cannabis program was established with very clear, finite boundaries on it so that it wouldn't grow unwieldy, it wouldn't grow large, it wouldn't expand. It was meant to provide a compassionate alternative medicine to people who could benefit from that, but not to have the proliferation of expansion. One of the things that we often hear is that this will help make a product a little bit more affordable. We appreciate right now that the alternative treatment centers offer discounts to their patients. If you look at the annual reports, I believe that each of them offered, at least in the year that I looked at in 2024, almost close to $500,000 in discounts to their patients or their card holders who could not afford full price. There are a few reasons why the alternative treatment centers, although the intention is good in this bill, there's a few reasons why the alternative treatment centers will never be able to compete with the marijuana prices of our neighbors. In Massachusetts, Vermont, and Maine, there is an overabundance of marijuana retailers to the point where they are starting to lower their prices and go out of business. In Maine, one of the things that they have a real big issue with is actually black market marijuana. There's hundreds of cartel-owned Chinese black market grow houses in Maine, and these actually are pushing even more product into the market and lowering prices for legitimate retailers. And again, this is Maine also has a different way that they do medical marijuana grow and sell. They don't actually have to test their product, and Mr. Simon could probably speak on this as well. But what it allows is it allows their products to be quite cheap, and people can sell them that. And that's why a lot of card holders will want to go to Maine. So all I'm saying with this is that the goal of this is to lower the drug prices, but we're not ever going to really be able to compete with our neighbors, and it's something we're going to continually chase. And the last thing I want to say, there's an important note in this bill. The bill also states that towards the bottom, the department shall, in conjunction with the local governing body of town and city where the additional cultivation locations would be located, they would solicit input from qualifying patients, caregivers, and residents of the town, which in the additional cultivation location would be located. So I'm just going to say right now that what that does is that notifies thousands of medical marijuana card holders of which town is going to consider a cultivation site. And quite frankly, it gives that town a disadvantage because you could have a whole bunch of people show up and put a lot of political pressure on that town. Because this is written into the bill, in some ways, it is state RSA sponsored lobbying. This doesn't say that we're going to notify law enforcement of the surrounding towns. This doesn't say we're going to notify drug prevention coalitions. This says we're going to notify the card holders so they can go to that town and advocate. And I think that at the very least should be removed from the bill. Thank you.
Thank you. Any questions? Yeah, Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question. You may not know the answer to this, but I'm just curious. Did the black market issue arise in Maine when they only had therapeutic cannabis?
Not to my knowledge, but what ends up happening when a state legalizes is it allows the black market to operate in plain sight.
Mm-hmm.
And Maine has a lot of remote areas.
Mm-hmm.
It's allowed people to come in. Maine's also a state, kind of like New Hampshire, as you stay out of my business, I'll stay out of yours. So people, it's a place ripe for people to be able to kind of come in, be left alone, and do their thing.
Mm-hmm.
And unfortunately, the people that have come in and been left alone to do their thing are Chinese cartels.
A follow-up.
Follow-up.
It's my understanding that this bill really refers only to therapeutic cannabis. Is that correct?
Yes, ma'am. You asked me the question about that. What I'm saying is that the impetus for this bill is so that we could have lower prices, because we, and Mr. Simon can probably can speak to this, but medical marijuana card holders go around to the surrounding states to get their product. And they do that because it's cheaper. And I'm just asserting that there's a lot of reasons why we will never be able to chase that price.
Mr. Chair, could I ask one more question?
Sure, go ahead.
For the individuals in New Hampshire who are patients and are depending on this, the cancer patients and Parkinson's patients, would you believe that they might not have the ability to travel out of state?
Yes, ma'am, I do. And as a matter of fact, I speak frequently to a lady in my town who's a card holder, and she struggles financially and things like that. All I'm trying to assert here is that we originally established our program with clear guidelines.
Mm-hmm.
This is an effort that Governor Sununu vetoed time and time and again, especially in his last year, because it expanded the card holder, the therapeutic cannabis program in a way that was never intended. That's all I'm trying to assert. And I know that I have great empathy for people. My friend's son actually passed away at 18 from, today's his birthday actually, from a bone cancer in Vermont. And he used therapeutic cannabis to ease some of his symptoms. So I'm very empathetic to that. All I'm trying to say is that we will continually keep expanding this program for 1,000 empathetic reasons, but we're going away from what we originally said we would do with this program. That's all I'm trying to say. Thank you, ma'am.
Representative Markell.
Yes, thank you, Mr. Chairman, and thank you for taking my question, ma'am. Can you tell me about how many card holders would be affected by this bill?
I know that the cardholder roster, Dr. Knurr can speak to, and the last time I checked, it was anywhere from 13,000 about a year and a half ago, but I heard Senator Pearl give an estimation of 17,000, which seemed a little high, so I'm not really sure that number exactly.
Okay, follow up, sir?
Follow-up.
Thank you. What I mean by that is the people what percentage of the card holders out there who are non-ambulatory, who would need this bill?
The card holders that are non-ambulatory already have the ability to access therapeutic cannabis through their card holder. What you're probably referring to, and then we also have provisions in the law that they can have, I think, up to 1 to 2 designated caregivers for non-ambulatory people who can then go and get their product for them. That is already a provision of the law.
Okay, thank you.
Thank you.
Other questions? Representative McLean.
Thank you, Mr. Chairman. Thank you for taking my question. So I'm trying to understand the concern a little bit. Initially, when this program came in, I understand that there were guardrails X. But as you mentioned, there has been a lot of proliferation that we see going around in the neighboring states. And specifically, you know, you referenced the black market. And the black market, you really don't know what kind of product that you're getting. So even though you can't close the gap with the black market, as you say, you can certainly maybe make our product more attractive. So to the extent that it can do that, is your concern just that we're pivoting away from original intent, or what do you see as the danger in pivoting away from the original intent? I'm just trying to understand where
Yes,
the
sir.
concern lies.
The concern is that we are pivoting away from the original intent, and this is the and I don't mean to sound negative about this, but this is the constant bait and switch that happens with drug proliferation, whether it's recreational legalization or the therapeutic cannabis program. Medical marijuana was ushered in, quite frankly, on the backs of sad, suffering people who are dealing with so many things, and you want to give them the ability to ameliorate that suffering. It was to give them legal access to have that product. But then all of a sudden, then it shifts from, well, now they have to, now we have to make it more affordable. Now the ATCs say that they, might need the funds to expand their operations. Now we need to do this. Now we need to do that. And we make these decisions without actually looking at all the ways in which we've tried to address those things. Non-ambulatory patients, designated caregivers, people not affording be able to afford their products. Then you have the ATCs who offer discounts. We just keep expanding it. That's all I'm saying. And the one thing we actually never do is we never actually open the books and look and see why can't the product be a little bit more affordable. Are the ATCs, and no insult to them at all, I'm not trying to, but are they, is the money where's the money go? The ATCs fund our therapeutic cannabis program. What are the salaries they're getting paid? I mean, the legislature, you guys are just getting told we need this because we need to do this and it'll save money and all that, but nobody knows if it's needed to be affordable or if it's just to expand the program. That's all. I'm so sorry. I'm going to have to head out. Thank you.
Okay.
Thank you, sir.
Thank you.
Representative Tellez.
Yeah, thank you. I didn't quite catch what organization you're from.
Smart Approaches to Marijuana, the New Hampshire affiliate. Thank you.
Okay, thank you. Okay, Representative Kinnick, would you like to testify now?
I just knew she had a time constraint, and
Sure.
even though we're on opposite sides,
That was
she
very nice
deserves
of
her time.
Very nice. of you to do.
Absolutely. Okay, yeah, so I'm Jerry Kinnick. I am the chair of the Therapeutic Cannabis Medical Oversight Board, which is charged with medical oversight of the Therapeutic Cannabis Program. We have 10 different medical providers, a ATC rep, a Department of Health and Human Services, medical staff, and a clinical representative from an ATC. We voted 7-0 with one abstention to pass this bill, and the reason is because it will improve our ability to offer lower prices to patients. Indoor cultivation, as is currently required, really increases the cost of production, secondary to electricity needed for sufficient lighting and for heating to obtain good plant growth. Growing in a greenhouse will allow the use of sunlight and make that a great deal cheaper. The energy input from the sun is really amazing. I'm a home gardener. I've got a little double wall polyethylene greenhouse that I use. And by mid-February, I have to make sure my exhaust fans are plugged in and running because the temp gets over 100 degrees on a sunny day in February. And last Thursday was a kind of mediocre, dark, cloudy day, only 44 degrees, but it was in the upper 70s on my greenhouse. Now, it is important. Competition with our neighbors on price is not the point. It's true, we have increased costs because of our regulation. That's what makes it a good program. We have a very highly regulated program. Yet it's true, they don't even test the products in Maine. We do. We mandate that. That increases costs. We have a great deal of security in our program. All those things are put in place to make it a good program. The solution is not to remove the regulation and make it a crummy program to lower costs. The solution is to figure out how we can be efficient and maintain a high quality program. And we can do that. And sure, it's only going to decrease it a little bit, but this isn't a matter of expansion. It's a matter of responding to needs. And also, just by the way, if you go to Maine, yes, some of our patients do that. If you go to Maine and get a product and go across the state line, it just happens to be a federal offense, but minor point. It's probably not enforced very much. Also, those opposed to the bill have stated that there are no security requirements that came out in the Senate hearing, but that's not correct. Lines 17 to 19 demonstrate that we have to meet, the greenhouses will have to meet all of the current security requirements law for ATC cultivation facilities. And in my testimony on the back page, you'll see a summary of what those requirements currently are. Those are under administrative rule pursuant to the statute. In addition, lines 8 to 12 authorize the department to adopt further rules regarding greenhouse-specific requirements if they're determined to be necessary. These are not little flimsy double-wall polyethylene greenhouses like I've got. They're buildings with solid walls with good security. There's not going to be any loosening of security if this bill is passed. Another objection has to do with the public hearings. That language regarding the solicitation is there, but the department does not send out a notification to to patients about this at all. These are public input sessions in the town or city. They are widely publicized in the department's website and in the local town and city, both in newspapers and all kinds of other things on their website. They're in addition to local planning and planning board meetings, zoning and planning board meetings, and they're consistent with what has been done for all other cannabis facilities, ensuring that the facilities would be subject to public input and local control. So in summary, in summary, one of our problems is high cost. This will enable lower cost production, lower cost for patients, but maintaining the high level of security and high quality of the program. Thank you. I'll take questions.
Okay, thank you. Representative Palazzo.
Thank you, Mr. Chair, and thank you for being here advocating for this important piece of legislation. So historically, do you see like any significant changes since the last session when similar idea didn't go through all the chambers? And also, do you think this committee can do anything to improve it and make it like more amendable for opponents of this idea?
Yeah, I think some of the changes, I think there was some, I don't have the previous one with me, but I think there was some comment about seeds in the previous that was removed. More importantly, is there were more, it was made more explicit about the security requirements from the previous bill, the previous House bill that failed in the Senate.
Thank you.
I don't see anything we can do to make it better, actually.
Other questions? Representative McLean.
Yeah, thank you, and thank you. Nice to see you again, as
Absolutely.
always. And I just want to talk about the comparison to the black market, which you spoke to directly. Are you aware, though, of any? I'd be interested to know: is there any data anywhere that talks about overdose or anything related to marijuana on the black market relative to the regulated product?
The major problem with the black market is basically it's not a regulated product. You have no idea what you're buying. A lot of our patients, and remember, the goal in therapeutic cannabis is to get a therapeutic effect without that pesky side effect of intoxication.
Right.
Joe Shapiro always liked that line, but he's not here for it. In any case, because that's a side effect that is not desirable. If you're 80 years old and you've got pain and you need to take some cannabis at nighttime so you can be comfortable. When you get up to go pee at 2 a.m, you don't want to fall over and break your hip. So you need to know what's in your product. You need consistency. All products coming out of ATCs are tested as to the cannabinoid profile. You know what's in them. You also know that they've been tested, so there's no contaminants, no mold, no heavy metals, no pesticides. Those are very important things. You don't know that with the black market. There also was, for a short time, as I remember, lacing of black market marijuana with fentanyl, other drugs. You don't get that. So the key is you can get a safe, regulated, and tested and labeled product from an ATC. And that is really what makes it a safe system. Yeah.
So quick follow-up. So on the council, or in discussion with the ATCs, do they have any idea, or do you have any idea what the potential recapture might be if this was to go forward? Have they done any projections with respect to that?
Perhaps Matt Simon might be able to answer that better. There is a requirement here that we have to, in their annual reports, they will have to talk about the impact, so they'll need to generate those numbers. But, you know, again, I've been doing greenhouse growing for over 10 years, not cannabis, just purely vegetables. And, and it's, you know, it is amazing what you can do with the power of the sun. And when you do an indoor grow facility of any sort for anything, it takes a lot more money for the heating, for the light, because you have to have really high intensity light. If anybody's tried to grow, you know, their seedlings underneath just a crummy little light, they'll find out that they look awful. You need really strong lights, and that takes a lot of energy.
Any other questions? Representative Tejas.
Thank you, Mr. Chair, and thank you for taking my question. I'm intrigued by what was shared by the prior speaker about what happened in committee and how it came out of committee ITL. Can you illuminate us
Yes.
a little bit?
Shall I say, it was before judiciary, who have traditionally not been very favorable to our bills. I think that's my diplomatic way to say that. But the fact that it was overturned and passed on a voice vote is pretty compelling. Yeah, I mean, I'm here in front of HHS, who looks at it from the health point of view. Over there, it's looked at as a criminal thing, and it's not. It's illegal in our state.
Other questions?
Hope I don't get in trouble for saying that.
Representative Markell.
Yes, thank you, Mr. Chairman. Yes, sir, and I appreciate your testimony. A couple of questions come up, and if I'm understanding this correctly, I'm looking at line 20, and I'm looking at lines 20 to 23, dealing with local governing bodies and things like that.
Yes.
Okay, what types of opposition would you anticipate coming if somebody wanted to open an outlet like that, or a grow store?
I think the main issue that you might see is like the zoning type stuff. Somebody might say, you know, we're a rural area with a bunch of trees. We don't want to see a great big building over here. The same thing you see with just about any other expansion of, or large retail outlet or something, which is why the zoning board's going to get involved. So it's going to be in a place that is zoned appropriately. And it has to be subject to all the town requirements and zoning. Because this isn't even selling. I actually, many years ago, one of the ATCs was looking into opening a branch in Conway, and I went to that hearing, and I don't remember any really particularly negative things, because it was just a simple storefront right there with a bunch of other storefronts, and doesn't look any different than the rest of them. This will be a larger building. And because of the security issues, things have to be cleared away. The trees have to be cleared away. There has to be lighting. I suppose there might be objection to that, but if it's in a commercial zone, that won't be a problem. And I doubt they're going to stick it in the town of Freedom, for example, where I'm from. They're going to be probably putting it in a large, there may be some empty warehouse or unused warehouse that might be perfectly appropriate to remodel and put in a translucent roof and do it there. So.
Okay, thank you.
Yeah.
Anyone else? Seeing no one else? Okay, thank you.
Thank you. Good to see everybody again.
Good to see you. Also signed up to speak is Matt Simon from Granite Leaf Cannabis.
Thank you, Mr. Chairman, Honorable Committee. Good to see you all again. For the record, Matt Simon. I represent Granite Leaf Cannabis. I've been working on medical cannabis policy in the state for 19 years now. So we support the bill. This has passed the House in some form overwhelmingly in recent sessions. The problems have been on the other side of the wall and with the previous vetoes by the previous governor. This year, that logjam did get broken in the other chamber. The Senate did have a shift from last year and did approve this. So it is back before you, and I hope you will view it the same way you viewed similar bills in recent years. This version is actually a little bit more, has a little bit more language to address some of the concerns that have been raised. For example, instead of assuming that we're going to reduce costs, that is explicitly stated in the bill. If we want to operate a greenhouse, ATCs have to submit a detailed proposal to the department and include the alternative treatment center's plan to reduce energy costs and provide lower prices for registered patients. One of our biggest expenses is electricity to power the lights and then to control the humidity and the temperature in the grow rooms. Outdoor cultivation, greenhouse cultivation are legal in neighboring states. They're not controversial in other states. There are other aspects of policy in Maine in particular that are very controversial. I'd be happy to talk to you about those. What we're talking about here is a bill that would allow 3 companies that are heavily regulated in New Hampshire be able to operate 3 additional greenhouse cultivation locations that would be subject to all the same restrictions that we're currently subjected to. It's not about expanding, it's about growing some of our product differently and more affordably so that we can be responsive to the #1 complaint about our program from patients: price. We have reduced our prices between 30 to 50% across all product categories over the last 4 years. We're trying to reduce our prices even further because we understand that patients have difficulty affording therapeutic cannabis in New Hampshire. None of it's covered by insurance. All of it comes out of their pockets. We're trying to keep patients from having to seek cannabis from the gas station, from the illicit market, or driving to Maine to buy it from an unregulated storefront there. We're trying to make this limited program work. That's what this bill's about. So thank you. Happy to take any questions.
Thank you. Any questions? Representative McLean.
Thank you. So I'll ask you the same question I asked the first person. So I think there's enormous benefit in pulling whoever you can off the black market and offering them a regulated product. Have you done any research or have any feel at all for what the recapture rate might be if we go forward with this legislation?
I think it's really difficult to quantify that.
Okay.
We know the number of registered patients in the state. It's currently about 17,500. That number fluctuates. It's not a secret, by the way. Anybody could just ask the department and they'll tell you. But it is currently around 17,500. And of that population, some of those patients never go to a New Hampshire ATC. They get their card and they go to Maine immediately because they know it's so much cheaper. There is, incidentally, a bill in Maine right now trying to mandate lab testing, and it's very contentious. And there are competing press conferences this week and rallies, so we'll see how that goes. We can't change Maine. It's incredibly easy to become a caregiver in Maine. You can set up a greenhouse, not tell anybody about it, grow as much as you want, sell it in your storefront that isn't regulated. That's Maine's system. We're never going to be able to compete equally with that system. I hope it changes. We're trying to do the best we can within the system, and we know it'll be substantial. Patients come in all the time. They say, I really like the service I get here. Love the education that I get. The products are tested. All that's great. I can't always afford it. Sometimes I have to go elsewhere. We're trying to reduce that.
Representative Lucas.
Thank you, Mr. Chair. Thanks for taking my question. Can you give us an idea of what the difference in costs would be?
Sure. So when the therapeutic cannabis program first began serving patients, incidentally, 10 years ago, I think April 30th is the exact 10-year anniversary of the first ATC sale. It was $55 for 1/8 of an ounce of cannabis, 3.5 grams. That is now in our state or our company between $33 and $39 for that same 1/8 of an ounce. So we brought it down quite a bit. You can go to Maine and find it much cheaper than that, maybe $15 for 1/8. So if they do, mandate lab testing, you'll see that number go up immediately. But it is a significant cost difference, and we hear about it.
Follow up?
So right now it's around 33, you said 33 to 39?
Yeah, we have two price points. One's 33, one's 39.
Do you have any idea what it would drop to if this bill were to become law?
Well, it won't drop immediately. First, we have to seek approval to build the greenhouse. Then we have to build the greenhouse. Then we have to start growing in the greenhouse. So it will take time for that to happen. But once a greenhouse is up and running and producing lower cost cannabis, I mean, we make a very broad range of products. If you go to our menu, you'll see edibles, suppositories, tinctures, whole range of things. But it all starts with the cannabis flower. And if cannabis flower is incredibly costly for us to produce, then everything that we produce is going to be costly. So it would significantly reduce the cost of our number one ingredient in everything.
Other questions? Representative Weber.
Thank you, Mr. Chair, and I apologize for being late. I feel like I was cutting class, but I was actually over at the Senate. And thank you for taking my
There'll be
question.
no detention, Representative Weber.
Thank goodness. Thank you for taking my question. My first question is, how does the recovery of the cost of construction and getting the greenhouse all set up interplay with the cost? Because it costs you to get this up and running, and what's the timeline for recovery of cost versus the declining price?
Yeah, that's a great question. I think it's one we'll have to answer before we can submit a detailed proposal to the department. We haven't done all the work to figure out a timeline and an exact cost, but we know that it will be worth doing because it will dramatically increase the affordability of our products and improve our service.
Matt, it's actually a whole different question, and it's a would you believe question, but would you believe that having visited one of your facilities as part of a legislative delegation looking at it, it was significantly more secure than a visit to the secure psychiatric unit in the correctionals facility here in Concord, because you took my driver's license away and they don't do that in the correctional facilities. So I was really impressed by that.
I would believe that. Thank you for the question. And we did give you the license back, right?
Yes.
Good.
Representative Markell.
Yes, thank you, Mr. Chairman. Earlier, we heard talk, sir, about unregulated marijuana being sold in Maine and so forth. Okay, and I'm inferring that you also regulate the content of your product?
Yeah, we're required by law to have every batch of product tested by an independent lab, and we're required to report those batch-specific test results to patients.
Follow up? Okay, and do you regulate the strength of the THC that's in your product?
Absolutely. Every product is labeled with potency, inhalables with a percentage, edibles with a milligram total. It's all very clearly labeled.
Can you tell us what they are? The THC levels?
They range dramatically. We produce, low dose edibles and tinctures that start at 2.5 milligrams of THC per unit. Some patients have very different needs and build a tolerance and have severe pain issues. So we make much more potent edible products. And for inhalable products, it's a range from single digits to, well up above 80%, some products, but it's all very plainly labeled.
Okay, thank you.
Anyone? Representative McLean.
So, yeah, just a quick question. I mean, we've talked about this bill, it's come many times before, but it hasn't gone the full distance. Obviously, this time it's come the other way. It's gotten through the Senate. So, as written, do you see any barriers on the governor's side with law enforcement? Anything? We have good buy-in there, or is there something that we should be looking at to further amend with this, or are we tight with this package?
Yeah, thank you for that question. There were a number of concerns that came up last year, and the bill was redrafted with an eye to addressing those concerns, and I believe we've done that. I believe it is as tight as it can be and needs to be here. I believe state police did oppose it at one hearing last year, and they have not opposed this version of it. The only opposition has been from Project SAM, who you've already heard from. They are a national organization. They have opposed medical cannabis in the state since the very beginning. They were the lead organization opposing the bill that created this program 13 years ago. They've opposed pretty much every bill trying to improve it ever since. So they've been the only opposition that I'm aware of.
Thank you.
Anyone else? Seeing no one else? Okay, thank you.
Thank you, Mr. Chair.
No one else has signed up to speak on SB 468. Does anyone else wish to? Seeing no one, I am going to close the public hearing on SB 468 and open the public hearing on SB 520. Could somebody change the sign on the witness table, please? We're a couple of hearings behind there. Representative Hartnett is not here. Yeah.
There are quite a lot of members of our committee over at the Senate for one reason or another.
I
So it's
understand.
that time of year.
Thank you, Representative McGrath. Okay, again, I'm going to open the public hearing on SB 520 and recognize the prime sponsor, Senator Reardon. Welcome back to the witness table.
Thank you. It's been a pleasure spending the morning with you here. My name is Tara Reardon. I'm the senator for District 15, Concord, Bow, and Hopkinton. I filed SB 520 this year after I received an email from a constituent that lives in one of my district towns here, and it's in italics on the sheet that I passed out. And it was so compelling that I decided that was the testimony here. She introduces herself, her name, and the town that she grew up in, and says, now having retired from the Air Force and a second career in the defense industry, she lives back in her hometown again. In 1986, she was a senior at the high school in her town. Her bra size was 34EE or 34G, and she was never able to find bras that fit, and she had to accept the closest she could get. My chest size was on my mind every morning when I tried to get dressed for school. I skipped out of dressing for gym class every chance I could get. Running was difficult, humiliating, and painful. I still have the divots in my shoulders created by the weight of my bra straps. I'll apologize in advance for this language. Carloads of boys would drive by my house and scream tits. I hated every second of high school because of my breasts. It wasn't until I entered the delayed enlistment program for the Air Force that my mom suggested a breast reduction surgery. I would not have been able to do the jumping jacks or any of the runs if I hadn't gone through the elective breast surgery in high school. Although I still regret that my doctor refused to reduce below a DD, that reduction was the best thing I did in my entire life. Before surgery, I avoided running at all costs. Afterwards, I became a runner and even competed in several sprint triathlons. Before surgery, I could not wear button-up blouses. Afterwards, I was able to wear my Air Force dress blouses without tailoring. Before the surgery, I avoided any chance of being called on or singled out. Afterwards, I literally blossomed, winning awards and medals in the Air Force, graduating the top of my language classes, selected for a commissioning program as an electrical engineer, graduating at the top of officer training school, Squadron Officer School, and sought after mentor for younger enlisted and commissioned women. My point is not to brag about my accomplishments. There were hundreds of women who did much better than I, but I want to show the transformation in my life that would not have happened if I hadn't been able to elect a breast surgery reduction in high school. Since I brought this legislation, the number of people who have said to me, I know someone or I have a family member that has gone through that same thing, not necessarily while they were a minor, but possibly their life would have even been better if it was if it had been done when they were minors. We did pass legislation last year that was specific to trans kids, and the surgery that minors were undergoing. It just went a little bit too broad, and it would have excluded this woman who, as you can see, had a compelling story and didn't necessarily have the medical prognosis to make the change, but in fact, it was a life changer for her. As soon as that legislation passed, she reached out to me and sent me this exact email here. So we're just trying to broaden the scope, adding one section to 32953, Roman 2, D and E. After that, an additional section F, at the election of the minor in consultation with her primary care physician. And I really hope it's language that the committee can support. Thank you.
Representative Mazer.
Thank you, Mr. Chair. Thank you for taking my question. Can you tell me the definition of symptomatic macromastia?
I can't, although I have Googled both of those definitions in there, and they were not inclusive of a high school girl where it was a lot of her, she had some physical limitations, of course, because of her breast size, but mostly it was emotional for her.
So, yeah, are you aware that there's currently an exception in that RSA that's referenced in here? That the procedure is, the exception is a procedure needed to correct gynecomastia and symptomatic macromastia. If you look at the definition of macromastia, it's exactly what I'm reading in this testimony. So would this legislation be redundant to what's already in law?
I don't believe it is. I don't think it's clear, and I think that we have found routinely that physicians, when the law is not clear, do not tiptoe into something that could be liability for them, when this was not necessarily a diagnosis for that child, but it was a conversation and agreement between the two of them.
Follow up.
Yeah.
And the parent.
So I have the definition of macromastia right in front of me, and it pertains to enlarged breasts. And it's a syndrome that has persistent headaches, neck and shoulder pain, etc., etc., etc. Again, everything I'm reading in this testimony. So, I'm confused where you said that, like, the diagnosis, would it, in this testimony, a doctor, would they not diagnose this as that?
So she did not have headaches. She had divots in her shoulder. She didn't necessarily have the symptoms. So for clarity's sake, instead of pigeonholing a doctor into making a diagnosis, it's done at the election of the conversation between the primary care physician, the parent in this case, because she was a minor, and the child.
Thank you.
Representative Lamus.
Hi, thank you, Mr. Chair, and thank you for taking my question. So, are you saying that the doctor shouldn't have to diagnose this condition before surgery is performed?
I am saying that in the instance before us here, the constituent that I had, the doctor had not diagnosed her, and sometimes if it's unclear, and you have a doctor on the committee here who
Actually,
may
more
be
than
able
one.
to clarify that, if the doctor is unclear that this patient fits into the category of that diagnosis, she doesn't have symptoms. She doesn't have headaches. She's young and she's in really good shape. She doesn't have backaches. She's able to carry her posture. Then if she doesn't comfortably fit in there, would a doctor be comfortable saying that diagnosis for her when in fact it is impeding her lifestyle? That is why she wants the breast reduction.
Yep. You have a follow-up?
Follow-up, thank you. Thank you for taking my question. I'm trying to form it in my head. So, what I hear which would not be a question.
Yeah, we need a question.
I know we need a question.
Would you believe?
Well, no, it's not a would you believe, it's a question. I'm just questioning whether or not I'm still not clear about you not having a prognosis or diagnosis arrived at by a physician before there is surgery. I guess I don't even know how to form a question with that. If you could just give me a better. Yeah, thank you, Representative Mazur. I withdraw my question.
Representative Mazur, go ahead.
Yes, thank you. So I'm reading the testimony, but it sounded like you were leading us to believe that it wasn't in here, but it says running was difficult, humiliating, and painful. I still have the divots in my shoulders. Again, definition of macromastia. Physical discomfort of the individual that restricts exercise and activity. What she's saying falls right into that. That is currently an exception in the law. Would you believe that would be the case?
I believe what you're reading for the definition of that, and that's great if somebody can fit into that box in consultation with her doctor. He did it because of her lifestyle and her inability to do things, and I don't think she ever got a diagnosis, is the point that I'm trying to make.
Representative Plaza, did you have your hand up earlier? Then Representative McLean.
Yes, thank you for taking my question. Do you have a definition for breast reduction surgery? In the testimony, we see that the reduction was done to the DD level. So how low can it go with breast reduction surgery?
I don't know the answer to that, and I think that's probably patient specific between a doctor and a patient.
Follow up.
So can it go to zero? Like can like complete removal be part of breast reduction surgery?
I don't know the answer to that.
Representative McLean and then Representative Palmer, I think you had your hand up.
Yeah, thank you, Mr. Chairman. Thank you for taking my question. So Representative Mazur, just listening to some of her questions for you, it kind of sounds like we're already covered. But you mentioned, I thought, that people had reached out to you with instances where there was denial. Did I hear that correctly? I'm just trying to understand, is this needed, or are people actively being refused because there's some misunderstanding?
So the current law hasn't been into effect very long. This is a case of a minor. The instances that people have related to me have been both adults and minors that this has happened with, and this was a result of the law passed last year.
Okay. So just a quick follow-up. So at this point, it being so new, you're not aware of anybody being refused this kind of thing at this time. This is going back in the past. You're not aware of anything, so this is kind of preemptive. Is that where you're going with this, or?
I think in response to my constituent reaching out to me with this scenario, she does not believe that she necessarily fit into the diagnosis in order to get the breast reduction, and asked that I bring the legislation.
So just a final question to clarify.
Sure.
So, but again, so she's reaching out saying this is but you're unaware of any actual refusals to do this kind of surgery at this time.
I am unaware of that.
Okay, thank you.
Representative Palmer, did you have your hand up earlier? Or?
Sort of.
Okay.
So my question is, what this is really, is what this bill is doing is if the person does not fit the criteria in D of macromastia, but they have other reasons, like psychological reasons, that their life is just a total misery, then they should be allowed to proceed. And that isn't covered in D, because the physician, in that case, the patient doesn't have classic symptoms under what is in the current law. So this does really expand the options that a patient would have.
In consultation with their physician, yes.
Right, okay.
Okay, I am seeing no other questions. Okay, thank you, Senator.
Thank you.
No one else has signed up to testify? Are you here for 520? Okay. Could you give us a pink card, please? Give it to us now, if you could, please. Yes, please. I understand.
The theme of the day.
The logistics of us being over here and so many other hearings being over there is difficult. You got written testimony? Okay, sure. Thank you. Okay, for the record, Beth Scare is now before us.
No.
You have to hit one is the red light, yeah.
Hi, Beth Scare from Nashua. I'm here in opposition to SB 520. I have my testimony from when it was, before the bill was amended, when it originally was to repeal the ban on double mastectomies for girls, which we know is very harmful. Girls are getting these done because they think they can change sex, which we know is not possible. And I know it was amended at that hearing to restrict the changes to just allow breast reductions and similar kinds of surgeries. But I'm here in opposition to that as well because these doctors that are doing these surgeries are unethical, and many of them are claiming that they're doing breast reductions, and what they're really doing is double mastectomies, what they call chest reconstruction to make the girls try to make the girls look like boys. And I think the law that was signed last year was, works as is. It has everything it needs, and we don't need to loosen it up to allow unethical practices to be, done by these unethical gender doctors, gender ghouls. So please vote ITL on SB 520. Thank you.
Thank you. Are you taking questions?
Sure.
Are there any questions?
I do.
Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question. Were you here at the end of the senator's, when we were asking her questions?
No, I'm sorry, I missed that.
Okay. Just because I had asked if the current bill, which you mentioned, HB 712, addressed what she had amended this bill with. Did HB 12 already address that? But then she mentioned that this amendment change would allow for psychological changes, which, would you believe that I don't see anything regarding psychological changes in her amendment?
Well, so she's justifying that, saying they should be able to do this because they have a psychological problem. Well, that just opens up the whole can of worms again, because that's the justification for these double mastectomies for these girls, is that they're having body dysmorphia. They don't like their breasts, and they like the idea of looking like a boy. I mean, they're just kids. I mean, this is being done to girls as young as 13 years old, and it's just horrific they grow up and they realize that they've lost something very important.
Thank you. Representative Palmer, did you have a?
Thank you, Mr. Chair. I just had a clarification. She didn't say psychological. I did, and she did not refute what I said, but she was not the person who said.
She agreed. She didn't disagree.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. Do you think it's possible that a minor adolescent finds her large breasts very distressing and it's keeping her from playing sports as she would like to, that has nothing to do with gender ideology, and that she might be allowed to have this elective procedure? And this is what this amendment would do.
Well, my understanding is that the bill that was signed into law already covers everything that's needed for such an issue. And that we don't need to add anything more to it.
Other questions? Seeing none? Okay, thank you.
Thanks.
All set. You want to testify on 520? Sure. Thank you.
Thank you.
We recognize, Chair recognizes Representative Knirk. Former Representative Knirk. We never get rid of the title.
Yeah, but also a former surgeon. And though I was a spine surgeon, well, actually, as a spine surgeon, I sometimes did see people with macromastia who had back pain. That was a real issue. In addition, though, as a general surgery resident, I participated in breast reduction surgeries as well. I think, first of all, yes, since macromastia is in statute, it probably doesn't need this, but as a practitioner, as a provider, sorry?
I'm sorry.
Oh, that's right. As a provider, you know, sometimes you really are looking over your shoulder. You're looking over your shoulder enough to think, am I doing the right thing for the patient? Am I exposing myself to malpractice? And if you say, am I doing, you know, am I going to violate statute? It just adds another stress that you really don't need. So I think if having redundancy to make sure it's really clear would be okay. And actually, many of the definitions of macromastia do include anxiety and decreased body image, because that is a real problem for adolescent females who deserve to be able to do what they need to do. The comment was made about removing the breast entirely. That would not be a breast reduction. That'd be a mastectomy. And I think if a provider is doing that, they would be subject to discipline by their disciplinary board because they would be misrepresenting what they are doing. A breast reduction is decreasing the breast tissue. You're not removing it completely. That would be mastectomy. So just, I think actually the current statute probably does cover it, but if there's any confusion at all, it would not be negative to do this, though I would actually be in favor of adding to the various points that are made in F, lines 5 through 8, to also say, not just physical discomfort, individual restricts exercise and activity, comma, anxiety and decreased body image, because we need to make sure that that is something that the provider knows it will satisfy the requirement, so that it's clear in statute that if you have a woman who has very large breasts and is being taunted constantly and is afraid to even go to school maybe, and as I understand, may even have a higher risk of sexual assault, that she could do something about this. That would be wise to allow the provider to know they were safe by just adding that anxiety and decreased body image.
Thank you. Representative Lucas?
Thank you, Mr. Chair. Thanks for taking my question.
Mrs. Scare, did you have written testimony to give us? Oh. Thank you very much. I'm sorry.
That's all right.
Representative Lucas, go ahead. I'm sorry.
Yes, my question, thank you for taking it, is do you think it would be valuable to hear from the practitioners regarding their position and how their patient-physician relationships have been affected by the bill that was enacted last year, and also how this new bill proposal would affect that relationship.
Definitely. As I'm speaking, I mean, the last time I was scrubbed under breast reduction surgery would have been, 45 years ago. Again, I did see women with macromastia, with upper back pain particularly, and sometimes lower back pain as well, in my practice. But nevertheless, we really should be hearing from the plastic surgeons and the psychiatrists that work often together as a team to manage somebody with this problem.
Thank you.
Representative Mazer.
Thank you for taking my question. Would you believe that they had every opportunity to testify here today if they did have an issue with the current, with the legislation that was just passed?
That is a good point. And the question is, are they aware? Because I know that as providers, active providers, sometimes it's hard to keep up with everything that's going on. I mean, I have the luxury of not practicing anymore to be able to follow bills more closely. Yeah.
Follow up.
Thank you. Would you believe that they don't seem to have an issue following up with other bills? So I would think they would been able to take the time if they were really concerned about this today.
I don't know. That'd be a speculation on my part, and I should not do that.
Anyone else? Representative McLean.
Thank you, and thank you for taking my question. So with respect to your thoughts about the potential expansion of the bill to, include, for example, body image, and I'm not a doctor, so I'm asking this question as a non-doctor, but is it common practice that we would offer, say, elective surgeries for minors, because that's where this is going, for minors, for body image, I really would want to have a facelift because I think, my nose isn't good or something like this. It obviously for an adult, yes, but is it practice within the state that we would offer elective, I mean, forget the gender identity part of it. You know where I'm going?
Yep.
Dr.
Yes, I do. And having decided to testify in this approximately 4 minutes ago, I really don't have an answer. And I think it would be inappropriate for me to try to speculate what other providers feel.
Okay. Thank you.
Best I can do. Sorry about that.
Anyone else? Seeing no one else, thank you.
Thanks.
No one else has signed up to testify on SB 520. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on SB 520 and open the public hearing on SB 453. If somebody could change the sign. Thank you, Representative Lucas. And for the purposes of introducing the bill, I recognize Senator Prentice, the prime sponsor. Thank you, Senator.
Good morning, Chair McDonald and members of House Health and Human Services and Elderly Affairs. For the record, my name is Sue Prentice. I'm the state senator serving District 5, 15 communities of the Upper Valley, largely Grafton counties, parts of Sullivan County, and one lovely town in Merrimack County, the town of New London. I am here, as the chair said, to introduce Senate Bill 453 today. And the purpose of this bill is about increasing access to efficiency in healthcare with two particular changes. So going into this, and I see a few physicians in the room, and there's probably some nurses as well, or Dr. Wood. Physicians have served as the primary care provider, primary care providers become gatekeepers for referral services, as well as routine, say, certifications that need to happen for things like in this bill, accommodations for motor vehicles, and a statement for immunizations that there's a medical situation that's contradictory for an immunization. If they can't get to a primary care provider or physician, then it takes longer to get these things done. So what I'm doing here is something that I've done in some other areas, which is looking to include physician associates and nurse practitioners in the certification loop for motor vehicle, again, adaptive devices for motor vehicles, and for medical certifications
that there is a contraindication for a requirement for a vaccination. So two fundamental changes, vehicle waivers for folks with disabilities. So this would be a hand control or a pedal control or a pedal extension. Some folks who have disabilities, they say have suffered limb loss or they are unable to say their lower limbs do not function the way that others do in terms of their ability to regulate, press on the gas and press on the brake. They would be able to have an extension or a hand control depending on their disability, but they need to have a certification for that. And there becomes a bottleneck at times to see physicians only, respectfully. So that's why I want to broaden this out to PAs and nurse practitioners. And then the second piece with that, right now only physicians can sign for if a child has a contraindication, a reason that a medical reason for an immunization to be contraindicated for them. They shouldn't have it because it's not medically, it's not even appropriate. It's medically bad for them, but it's a requirement for them to have that immunization for school or for childcare. This would allow that physician associate or nurse practitioner to sign that certification form as well. So those are the two changes that I'm looking to make here. I do have, I'm doing this on behalf of, really the nurse practitioners and the PAs. And that's all I have to offer to start. And I'm happy to answer any questions you may have.
Okay, thank you. Representative Weber.
So am I correct in understanding that what we're asked to do here is to leave the statute exactly as it is, but to add to the categories of gatekeepers who can provide the necessary certifications on the one hand for vehicle use and on the other hand for exemptions for childhood immunizations?
Thank you, Representative Weber. I often call them the traffic cops. Gatekeepers, either one is fine. You are correct. Leave the statute the same, just changes who can provide these certifications. And it does, if I may say, it does reflect practice in a number of other areas.
Yep, thank you.
You're welcome, thank you.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. Do you think that, I think it's my impression that in many medically underserved areas, like particularly rural areas, that an individual is more likely to have their primary care provider be not a physician but an advanced practitioner. So would that make it easier for them to get all this paperwork done for their services?
Thank you, Representative Lamontagne. That's accurate. We know we have a shortage of healthcare providers. Physicians are at the tip of the spear in that shortage, and they I won't speak for the ones in the room, although I know them, but largely speaking, physicians have embraced the models of advanced care practice providers like PAs and nurse practitioners in partnerships in order to improve access. And rural areas do have more shortages than urban centers, even though, I'll say, like, my mother moved here from Massachusetts to Lebanon. Some of you might not consider that an urban center, but it is a city in the state, and she could, in one of 13 cities in the state, she couldn't get a primary care provider that was a physician. So she started out with a nurse practitioner, and it was a good fit for her.
Other questions? Representative McLean.
Thank you. Thank you for taking my question. Was there in the Senate, was there any testimony against this by physicians, or so no real opposition on that front?
Thank you for the question, Representative McLean. No. Some folks did sign in opposed to it, but in the day of, nobody signed in, nobody testified against it. I think we might have even exected that day, but I'd have to look at the docket to be sure. Thank you.
Representative Palmer.
Would you believe that primary care physicians really support this kind of legislation? Because otherwise we end up signing an awful lot of forms on patients that we don't know very well.
Good to see you, Representative Palmer. Yes, I would believe that.
Other questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is James Monahan, representing the New Hampshire Nurse Practitioners, I think that says. You're writing Mira's mind. I should be able to read it more easily.
Thank you, Mr. Chairman. As indicated, my name is Jim Monahan from the DuPont Group. I'm here today on behalf of the New Hampshire Nurse Practitioners Association. I have some notes, and the first line it is, good morning, my name is Kim Mohan, and I'm the Executive Director of the Nurse Practitioners Association. She actually was not able to make it here today and asked me to testify in her place. As Senator Prentice indicated, this is legislation that we worked with Senator Prentice on to bring forward. As this committee is well aware and has been discussed already this morning, there are an awful lot of folks in the hierarchy of care that receive their primary care through from nurse practitioners or physician's assistants for a lot of reasons, including the very important observation about access in rural communities. So over time, what we've tried to do is take a look at state statutes where there are requirements that things be signed off on or certified by physicians and try to update those over time. What we've always avoided doing is just doing a word search in the statutes, and everywhere it says physician, change it to physicians or other providers, because it's sometimes not always the case. So what we watch out for is indications where patients are having difficulties or having to have multiple visits in order to resolve these issues, and we bring them forward on a as-needed basis. And the two before you are ones that we're seeing in the NP's offices or even in FQHCs or others where there's as you've said, the physician is being asked to sign off on something the patient hasn't seen. So the two before you are with regard to motor vehicle equipment. If you read through the RSA that's amended, there's a long set of criteria that the DMV has that the provider has to certify. So it's not just at the nurse practitioner's discretion. They have to comply with that. So we've made there's no changes to that, and that's still the set of standards. And then the second matter is with regard to exemptions from vaccinations or immunizations rather that need to be certified under various positions of state law. So with that, that's a little bit of background, probably more than you needed on this, but we did want to offer to you and urge you to pass the bill. But of course, if there are any questions that I can carry back to the nurse practitioners, I'm happy to do that.
Okay, thank you. Any questions? Seeing no questions. Okay, thank you. No one else has signed up to testify on SB 453. Does anyone else wish to testify? Okay, seeing no one else coming forward, I'm going to close the public hearing on SB 453, and the next hearing is scheduled for 11 a.m. on SB 501. We will be in recess until then. Representative Nagel.
I helped him out.
That's okay.
He's intimidating the witness.
Okay, I'd like to reconvene and open the public hearing on Senate Bill 501. And once again, recognize the prime sponsor and welcome Senator Prentice back to the witness table.
Thank you. Good morning, Chair McDonald, and members of House Health and Human Services and Elderly Affairs. Again, for the record, my name is Sue Prentice. I'm the state senator from District 5, representing 15 communities, largely in Grafton County, part of Sullivan County, and one community in Merrimack County, the beautiful town of New London. I am before you today, again, thank you, to introduce Senate Bill 501. And before I go into detail, I just want to point out big picture. This is similar to the last bill in terms of it is going to change or broaden broaden who can provide and authorize, actually who can authorize certain, well, in this case, it's going to be seclusion and restraint in personal emergencies. So that's the change to the statute that I'm going to be asking for. I'm the part of the Department of Health and Human Services, but it is a similar nature to the last bill that was introduced. So again, I'm introducing this on behalf of the Department of Health and Human Services. And what we're looking to do with 501 is relative to the authorization for seclusion and restraint during a personal safety emergency, and allow it to not just be by physicians, but by physician associates and nurse practitioners. So we're going to be seeking, or I'm seeking to amend RSA 135C57, Section 5. This restraint and seclusion, and we talk about it here, is already authorized, but only for orders to do it by physicians. Again, we're looking because of staffing and the way that staffing is at healthcare facilities, and I do have some representatives from Health and Human Services to speak to this change, broadening the people that can do it, especially during a personal safety emergency, is in the best interests of not just our patients who are undergoing an emergency, but our care providers. So again, 135C57(5), again, authorizing advanced practice registered nurses and physician associates in addition to physicians to order seclusion and restraint during a personal safety emergency. Additionally, this legislation addresses any conflicts within state statutes, specifically RSA 151.21, which is the Patient's Bill of Rights, and aligns it with federal law, which is going to be 42 CFR 482.13. So I have department staff here with me, Rosemary Wyant, and I also have Meg Thompson, who is a nurse practitioner. She's a lead nurse practitioner at the New Hampshire Hospital, who are here to speak to some of the more detailed questions that you might have in terms of the day-to-day practice. But that's my introduction. I'm happy to take any questions, and what I can't answer, I have folks with me that can. Thank you.
Okay, Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So I just want to be clear because it says what's added is in the bold, and if I read it, it looks like not only are you letting the physicians associates and the ARPN, but also order of a physician. So as I read the original content, it could not be done without the consent of the person. So I guess, did the physician, I just want to clarify, was the physician already authorized, and we're just adding it to, because I just see the physician in bold as well.
Yeah.
So,
Thank you, Representative McLean. My understanding is that physicians were authorized. I looked to the department to provide the clarification on that, but it is bolded. You are correct.
okay.
Yeah. Yes, thank you.
Anyone else? Representative Weber.
I have two, if I might. Could I have the reference to 42 CFR again, please?
I'm going to be seeing my eye doctor next week because I'm really going to be needing new glasses. This is coming up all the time. No, it's okay. So it's 42 CFR 482.13.
And the question,
Yes.
which is it possible that right now because Representative McLean is correct about
Mhm.
the statute, is that we're operating under rules adopted by the commission rather than by something explicitly in statute.
Thank you for the question, Representative Weber. I'll let the department respond to that.
Okay.
Any other questions? Seeing no other questions, thank you.
Thank you.
And as Senator Prentice indicated, Rosemary Wyant and Reagan Thompson are here from the Department of Health and Human Services and the New Hampshire Hospital. Good morning.
Good morning. Good morning, Mr. Chair and members of the committee. My name is Rosemary Wyant. I'm an attorney with DHHS and I act as general counsel for New Hampshire Hospital. And I'm joined today with Megan Thompson, who is the lead APRN for New Hampshire Hospital. Senator Prentice did a great job introducing this, and I just thought I would make just a few clarifying points to give a little background and context. First, one note, my comments will really pertain to APRNs because New Hampshire Hospital uses APRNs as treatment providers. We just don't have physicians associates, but both are included, which is completely appropriate as they are both licensed practitioners at CMS. Just so that you understand the reason for our comments being around APRNs. One other quick point, and you're probably already aware, but I think it's important just to understand that restraint and seclusion are interventions that are used basically as a last resort. They are used when a patient is experiencing a personal safety emergency, and these interventions are necessary for the purpose of ensuring the physical safety of the patient or others, or the staff around them. And with that backdrop, this bill does three very simple things. First and foremost, as Senator Prentice explained, this allows APRNs and physicians associates to order restraint or seclusion when such an intervention is necessary. As I mentioned, APRNs are treating providers for many patients at the hospital and for other DRFs as well. And this is important because under current state law, those providers currently must contact a physician to obtain such an order, even though the physician may not be involved in treating that patient at all. The second thing it does is brings New Hampshire mental health law into alignment with federal law. CMS regulations and accrediting bodies such as the Joint Commission that accredits New Hampshire Hospital already authorize physicians as well as licensed practitioners to order restraint and seclusion. So that establishes consistency there. And the third thing it does is it eliminates any potential conflict with other state laws by using the notwithstanding any state law to the contrary language. And this is just because we're focused specifically on the mental health facilities and the mental health system, and RSA 151 under the patient's rights deals with this in a different manner. And with that, we're happy to take any questions, and Megan can provide information around APRNs in particular.
Okay, thank you, Representative Lucas.
Thank you, Mr. Chair. Thanks for taking my question. When seclusion or restraints are used, is there a special report that's generated?
Yes, and it goes through a review process that is created through, I believe, CMS. I believe JCO also has standards and protocols related to that. So that's something that's done every morning. Actually, I'm part of that review.
Thank you. A follow-up?
Follow-up.
And if this improvement in the law were a bill would become law, would there be any change in the reporting process?
No.
Thank you.
Other questions? Representative Weber.
Thank you. And I'm wondering if council can help me out with the fact that neither Representative McGrath or I can find the physician provision in the existing statute. Am I right in assuming it is currently in a rule made by the commissioner?
It is, excuse me, it is currently in rule, yes.
Okay.
Yes, and it's that, this particular paragraph didn't include the word physician, and for that reason, that whole section was added. It was just in this paragraph.
Right. What I'm trying, may I follow up?
Sure.
What I'm trying to get at is there was testimony that currently, if an APRN is in a situation that is emergent because there is a safety issue right now, they must find a physician to do the signature. And I'm just trying to find out where that comes from because I don't see the word on the page in the statute as it is now.
Yes, it is in rule.
Okay.
Yeah.
Thank you.
Representative Palmer.
Just to clarify, having worked in a critical access hospital where the ER was staffed with primarily physician's assistants, does this apply in emergency rooms or is there a separate law that deals with that?
Well, that's, excuse me. This only changes RSA 135C. So this is specific to New Hampshire Hospital and other designated receiving facilities that deal with, who admit involuntary patients.
Thank you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, line 6 of the bill allows for seclusion or restraint as a form of emergency treatment imposed by law or by rules. So the implication in that is that anybody can do that because an emergency situation has arisen. So I'm just kind of wondering what kind of things outside of that emergency treatment being imposed would you be ordering for? Because it looks like if I read line 6, I don't need to refer to a physician or a physician's associate. Anybody can do it in an emergency treatment situation. So I'm trying to understand what are the scenarios kind of covered by the first paragraph of the bill.
So say for instance, a nurse is able to say that this patient is currently having a personal safety emergency. They are within their right to then act in order to, without a physician present, and move forward with that seclusion or restraint if necessary, if all other least restrictive interventions have failed. And then the physician then can put in the order. Does that make sense? Right. Yeah, go ahead.
If I could just add to that, that initial intervention by the nurse, because this is, as Representative Weber indicated, this is an emergent situation. This is happening immediately. So that nurse can take initial immediate action, but within 15 minutes, but that only gets through the first few minutes. And then you have to get an order from a physician to allow anything further to happen.
So to just clarify then, that line 6 is covering, this is an immediate crisis situation. Anybody can go in to stabilize that situation. Even an EMT or whoever's there can stabilize the situation. But then to go beyond that initial 15-minute emergency, it's going to require the physician assistant, or the APRN.
That's correct. The reality, however, with rules, and it is that it's not just anybody. It has to be a person who is trained in restraint and seclusion practices. Because for safety purposes, and that's required by CMS as well. So, just wanted to be perfectly clear that it's not just anyone that can act. And then each hospital has to have a policy about who can be trained and is authorized to do this sort of thing.
All right, good, thanks.
Representative Weber.
And am I right in thinking, as I read this and as I think about the other questions, this actually secures more rights, more security, more protections from the patient, because it says you can't do it at all unless it's by order of one of the licensed professionals. So that concern of is anybody just running and doing it, even though it doesn't actually happen in practice, we are now conforming the language of the statute much more clearly as to who can act and under what circumstances they can act. And if it's the advanced practice nurse who's there, they have the right then and there to give the order and then do all the documentation and review afterwards as to why that was necessary. But it clarifies what is an exceedingly urgent situation because somebody is a danger to themselves or others.
That's correct. And also to your point too, everything ends up being, it is all a written order ultimately. Everything is in writing and everything is documented throughout the course of any use of seclusion or restraint, which is then reported and followed up on. So,
Any other questions? Seeing none. Okay, thank you.
thank you very much.
No one else has signed up to testify on Senate Bill 501. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on Senate Bill 501. Next hearing is scheduled at 11:30 on Senate Bill 441 FN. We will be in recess until then.
Wow.
Okay, I'd like to reconvene and open the public hearing on Senate Bill 441 FN and recognize the prime sponsor, Senator Victoria Sullivan. Welcome, Senator.
Thank you, Mr. Chairman, members of the committee. For the record, I am Victoria Sullivan. I represent Senate District 18, which is Manchester wards 5 through 9 in the beautiful town of Litchfield. And I'm here today to bring you Senate Bill 441 FN, and this is something that directly impacts my city of Manchester. As you know, New Hampshire is still undergoing an opioid epidemic, even though people don't talk about it as much as they once did. Manchester offers a lot of services to people that are in need, and unfortunately, we have seen people be dropped off at our literally the doorstep of our shelters and our recovery centers without ever calling ahead, without ever making sure that we had room for these people. Our police department has been stretched to the brink of their abilities, as well as our EMS, because of this situation. I work with this population of people regularly, and I have had people tell me that they were literally asleep in a park in another town and woke up in a park in Manchester. They were just transported here and left. It's a very inhumane way to deal with the situation that we have at hand. And this would ensure that any municipality that needed to bring folks into Manchester or any other town or city that offers services has a memorandum of understanding with that municipality or city, because that way we can ensure that we've got room for them, we can ensure that we have care for them, and we can make sure that people are being treated humanely and not just dumped like unwanted trash on our streets. And that is actually what's happening. Happy to take any questions. I will tell you in advance that the lobbyists do not like this bill. They actually tried to rewrite it to put it into a way that was a lot of mays, which will lead to a lot of litigation and even more costs for not only our town and my city, but towns that want to find themselves in the middle of this situation. So I would ask that it be passed as is. It does have the support of the Manchester Police Department, and I believe that this is the most humane way to work with folks. We did amend it in the Senate because there was a piece that I had missed about people that are in care in another town that would come to Manchester for a continuum of care, and they intend to go back to their town. So they remain in the care of their town. So we did take care of that piece so that they wouldn't need a memorandum of understanding for that. So say someone was in a nursing home in Goffstown, they needed to come to CMC. That would not pertain to this. They're covered. They're okay. They can continue that care at CMC, and then they'll be brought back to their town. So I'm happy to take any questions.
Thank you, Representative Weber.
Thank you, and thank you for taking my question. I just wondered about the language at the very end of the bill on page 2, line 16. Could you explain to me the addition of and the requirements of RSA 165-2D relative to the operation of a syringe service program within a municipality? How does that relate to what I understand to be memorandums of understanding, which the purpose of which are to let a receiving town know what's happening and who's fiscally responsible?
That was added by the committee. That's a committee amendment. So that's in addition to the bill, the original bill that I had put in.
Okay, so the answer is we don't know.
Right.
Okay.
Other questions? Representative McLean.
I'm from Manchester, Senator, and so we've seen a lot of people, one police department comes up, dumps and leaves, and we've talked about that. But with respect to, the intent of the memorandums of understanding, just to kind of role play for a little bit, let's say somebody from a donating town said, hey, we'd like to have somebody come into Manchester, but the resources aren't available at this time. We're up to the gills. So what is the thought about how we approach that kind of situation?
Thank you very much for that question. That is actually what's supposed to be happening with our doorways programs, that they're supposed to be calling ahead to make sure that there's room, and it's just not happening. So in that situation, they would be able to say, I'm sorry, we don't have capacity. You're going to have to make another call. Right now, what's happening is if we don't have capacity, that person's just left on our streets. So they're not getting any treatment and they're not getting help. They're literally, our police chief I don't think he's here today. But he did testify to this in the Senate committee that they actually saw that happening.
Follow up.
And so, as part of his testimony, was there a feeling or any data available that said within the Doorways program, there is actually unutilized capacity elsewhere? Was that put forth in the hearing at all? Or do you have any feel for what that is or not?
Thank you. He did not, but I can tell you, because I work with this population of people often, that when I've had to help someone get into treatment, I have been able to do it. I've been successful doing it. And if it's not, sometimes people see that we have a shelter and they think there's services there, so they just drop them there. That shelter has limited services and limited hours. We've had people dropped off there at midnight. Those doors don't open at midnight. That person stays on the street until 7 o'clock the next morning. So in the memorandum of understanding with the town, the guidelines would be laid out, but they would also be able to share where the services are in other parts of the state. These are things they should be looking at. Doorways did a lot to try to educate people on the services around the state. So that phone call comes in, they can say, we don't have services here, but they should be able to have up-to-date lists too of where they can send people to because of the Doorways program.
Thank you.
Representative Weber.
Thank you. Thank you for taking another question. So I'm trying to understand clearly what is meant by the memorandum of understanding, because normally I think of those as being sort of a governing document that's negotiated well in advance of some happening as to who is going to do which things with respect to that. This looks to me more like it contemplates an individual memorandum of understanding for each individual patient, or does it, which is it? Do you contemplate a broader agreement between, say, a town and a city nearby, or is this something that's going to have to be done patient by patient?
Thank you very much. I do see it as a broader agreement. So Manchester, surrounding towns, they will be dealing with, Hooksett, Londonderry, Derry, area towns around them, where other towns or cities would have services. They'd be reaching out to people around them, and that way we're keeping things more centralized too for those areas. We often, in the recovery community, one thing that's super important to successful recovery is keeping people where they have people, where they have community. And so when we're taking people, and we've literally had people from around the country just, and I hate to use the word dumped because it sounds so dehumanizing, but that's exactly what they're doing. They're picking up people in other parts of the country and dumping them in Manchester. I'm sure it's happening in Rochester. I'm sure it's happening in other towns. I only know, what I live. And my lived experience is that this is happening in Manchester. And then we have people that they just aren't given services. They're literally just left there out in the cold. And you can see over the winter we had deaths occur because of this.
Representative Nagel.
Thank you, Mr. Chair. Thanks for taking.
Your microphone's off.
Oh, sorry. Thank you. Thanks for taking my question. I'm out of practice apparently.
That's okay.
You may have already addressed your limitations in answering this question, but in section 2 of the bill, it refers to the Opioid Abatement Trust Fund, and it talks about Department of Health and Human Service changing rules and things like that. What I'm struggling with is I don't see that has anything to do with that section of statute, because the statute itself deals with how HHS administers opioid funds. I'm the vice chair of the committee. We don't do what that section says, nor is it in our purview to do that. So I'm curious why they put that under that section of statute. And I understand why it's there, but I just don't understand why it's in that spot in statute.
I'm very sorry. Could you tell me again where you're reading?
It's the accentuated stuff on line 8, page 2. I mean, the role of HHS is merely to just define how we're going to distribute funds. It has nothing to do with that kind of thing, and I understand that may need to go in statute somewhere, but I don't understand why it's there. And you said that was a committee amendment or something?
Are you on page 3? Is that where you are?
I'm on page
Okay, I'm looking at page 2, line 8.
Yeah.
The department shall also adopt rules under RSA 541.
That's it.
Okay.
Because it's under the opioid abatement rulemaking section 5. And we just don't do that. Nor is it in the statute that we do that.
I know what you're saying. That was drafted by OLS to be in that statute.
Yeah.
So I don't know if they put it there because that's where they would have to put this new piece because
Yeah.
they're not currently doing that. So that's probably why they added it there. Does
Yes.
that make sense?
Not really, but
I'm-
I don't get it because we're never going to do stuff like that in our committee. So I'm struggling to understand why it would be put there. At the same point, I understand why it should be in statutes somewhere.
Okay. I mean, and if the
But that,
committee
that
sees
gives
it,
us a responsibility, you know?
yeah, if the committee sees a better place to put that, I could definitely support that as long
Alright.
as, we're still addressing the issue.
All right.
And I'll be honest with you, this is not my wheelhouse. This is just my experience, right? So if it was education, I could tell you exactly where it should go. So I appreciate you bringing that to my attention.
Thanks.
Okay, Representative Woods.
Thank you, Mr. Chair. Thanks for.
I'm sorry, I'm used to the Senate now. This is such a big committee. I'm like, where's this? Okay, fine.
My apologies, a personal clarification on section 1, line 7. It says arrange for the transport of a homeless individuals or other persons, and then it gives a descriptor. Again, I don't. Is the homeless individual or other person meant to flow with in a grammatical sense and maybe legal sense as well, showing symptoms? In other words, the homeless individual has to show symptoms of addiction or another person, or is it meant to be on homeless individual and then B, a person showing symptoms? So, in other words, could just a homeless individual be transported? Or do they have to have drug-related symptoms?
No, it could be either.
So it could be either.
Yes.
Okay.
Yeah. They don't always go hand in hand,
Okay,
right?
so-
Yeah.
Other questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So my understanding that if department adopts new rules, there would be more clear guidelines and better enforcement. But my question is about current situation, treating people humanely and not dumping them as trash should be already against the rules. So what stops? I understand there are many moving parts. There's a person who is being abused. There's like, for example, Manchester Police, Manchester as a city, but why currently nobody sues or complains and not enforces humanly treatment of people?
Thank you for the question. I don't know why it's not being brought up more. I know that internally it's something that we've been dealing with in the city with other towns too. It doesn't just happen in Manchester. I know that towns around us have had it happen. People thought there was a shelter there wasn't, and someone was just like left there. So I don't know why. I think some of it is with our police force and our first responders. They're used to doing so much without complaint. I think this might be part of the reason that we don't hear it more often. But I can tell you that the Manchester police chief did come and testify, and he had personal experience with this when we had the bill in the Senate.
Representative Weber and then Representative Nagel.
Thank you again. And I'm following up on Representative Wood's question about the first page, line 7, transport of a homeless individual or other person. It seems to me that this is intended to be about, by its title and by section 165:2 on the description on line 4, it's confined to transport for substance use disorder treatment. And what I heard your reply was that this would apply to a homeless person who was not showing signs of needing substance abuse disorder treatment, or any person who needed that treatment. I'm concerned about the lumping in of a homeless person who does not have substance abuse issues, because the whole purpose of the memorandum of understanding seems to me to be the substance use stuff. So would you object if we just changed homeless individual or other person to any person showing symptoms of addiction or incapacitation for substance abuse related?
Thank you very much for the question. So in the title, it does say substance use disorder treatment and other support services. So
Okay.
sometimes we have people that are homeless that are not suffering from addiction, but they are suffering from mental illness. And again, we need to get them into some place where they're safe, where they can get treatment. So that's why I included the homelessness in this.
Okay.
And also you can have people that are suffering from addiction that aren't homeless. They're just,
Well, and
Right.
I'm pretty, excuse me if I, the other people I think I am clear on. It was the issue of the homeless person who does not show addiction symptoms that I was trying to clarify, and you have done that, so I thank you for
Okay.
I thank you for the clarity.
thank you.
Representative Nagel and then Representative McLean.
Thank you, Mr. Chair. Thanks for taking my question. I'm more in practice. I'm on. I have a rule of thumb, if there's a South Park episode that deals with a social issue, then it must be important because there is one that actually deals with this. So, with that said, is there any quantification about how often this happens in the city, how much the cost is to the city? Things like that.
I can reach out to them and I could probably get you that. I can just tell you that it's been a very taxing situation for our first responders and our police, our city in general, our homeless shelter, our support services. And again, if we know who's coming in, we can definitely prepare for that. But if people are just I got a call at midnight one night from a friend who said they had a friend of a friend was receiving treatment in Nashua, and they were done with their stay in Nashua Hospital, and they had to be put into recovery somewhere. They brought them to Manchester in the middle of the night and left them there. Was an elderly gentleman. He was a veteran. They just left him there, and they're like, "What can you do for me?" I'm like, "I can't do anything at midnight." So we found him. We brought supplies to him. Somebody stayed with him until we could work it out in the morning. But I mean, I just happened to know that person, and they thought, hey, maybe Victoria knows what we can do here, right? So if that, I just think it happens a lot more than we know about, but I know that it happens a lot because of what the police department and the shelters have said to us.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So with respect to the inclusion or non-inclusion of the homeless persons, you testified that, I went to bed in Henniker and I woke up the next day in Manchester. So even if you don't have mental health issues or something, you're homeless, you're living in a tent, you have a community, there should still be some protections, right? For those folks, that they're just not displaced willy-nilly and dumped. Do you have, is that where you're thinking when you're talking about including the homeless, whether they have associated issues or not? Or yes? Or no?
Yes.
Okay.
Thank you for the question. I mean, I spoke with people who, this young woman who was homeless and of course, she was suffering from addiction, because if you're so passed out, you don't know how you got to someplace, you're probably incapacitated. But she fell asleep on the beach in Hampton and woke up in the park in Manchester. So, I mean, these are just things where people are just being taken, and they're not saying, hey, I want help. They're just being taken and put someplace else. So I just think it's a very inhumane way that we're treating people with mental illness, people that are homeless, people that are suffering from addiction. And if the purpose is truly to transport them to get them help, we need to make sure that that's the end result, that we're actually getting them help.
Representative Lucas.
Thank you, Mr. Chair. Thanks for taking my question. Is there any sort of a statewide clearinghouse right now that
I
can
don't
be
think-
used?
So thank
Uh,
you for the question.
Sure.
I think the closest thing that we have is Doorways, where you can call and find out if there's a room. But even with that, I use Doorways. My niece was suffering from addiction, and I had to get her help pretty quickly. And I called Doorways for her. She's doing really great, by the way. 3 years sober, and she's got a baby, so she's doing great. But I had to call Doorways, and I had to give my name, my number, and sometimes this is information that people that are really struggling don't want to give. It was uncomfortable for me, and and I was calling for help for somebody else, so sometimes they're hesitant to make that phone call. But if we have somebody that's on the street that's helping them and makes that phone call for them, I think it's better. Like, I think if my niece had to make that call and they start asking her questions, we may have lost her. But because I made the phone call and set it up for her, that was one barrier that she didn't have to contend with. Thank you.
Representative Nagel.
Thanks, Mr. Chair, and thanks again for taking my question. I always love when I get the fiscal notes on my bills and
Me too.
my jaw drops. I'm curious because there is a large fiscal note here and I'm struggling to understand it. And I'm curious if you can explain it or if there's somebody from HHS after that will explain it.
There will be somebody testifying later, I believe.
Thank you for the question. I have been gobsmacked by a lot of the fiscal notes this year, to be quite honest with you. And it seems like everything that we try to do, that some department thinks that they need a full-time person to do it. This is going to be a memorandum of understanding between communities. So I really don't understand the fiscal note, to be frank with you.
Other questions? No, Representative Drew.
Thank you, Mr. Chair. So on page 2, line 1, it says any municipality found in violation of this section shall be subject to a $5,000 fine. Do you feel that that is enough to discourage this kind of behavior, given the cost and expense of treatment services and providing other support services?
Thank you for the question. So my intent isn't to hurt the taxpayers in this, but it's really to curb the behavior of the people that are making decisions on their behalf. And I think that if it got out that a municipality was being charged $5,000, $10,000 because they did it twice, $15,000 because they did it 3 times, I think it might be a deterrent for them. Again, I think there has to be some teeth in it. I just don't want that to come back to hurt the taxpayers that we're actually trying to protect in this bill.
Anyone else? Okay, thank you.
Thank you, Mr. Chairman. If I may indulge the committee just for one moment, I apologize. I won't be here to present my next bill. I've asked Representative Yuri, I'm gonna call your name. Representative Yuri, if he could please present my bill for me. I have caucus and I have to be there, so I apologize.
Sure. Okay.
Thank you.
Thank you. Also signed up to speak is Representative Rhodes from Cheshire County District 17.
Good morning. Thank you, Mr. Chairman. For the record, I am Representative Jennifer Rhodes. I do represent Cheshire District 17, which is Winchester, Richmond, Swansea, Troy, and Fitzwilliam. I am here today to oppose Senate Bill 441, and if you would indulge me for a few minutes, clearly I will explain why. The very first part of this bill, in Section 1, talks about RSA 165. So RSA 165 is the local welfare statute. However, when you read throughout this bill, Senate Bill 441 appears to me, even more so from here in the conversation that had just taken place, that this entire bill is dealing with harm reduction measures. So I, as you know, am over in criminal justice. I don't know anything about harm reduction measures as far as where it goes in statutes and all the complexities to it. But I do think that the way that this bill is written, where it says about, municipality or representative municipality that intends to transport, arrange transportation, so forth and so forth. But it goes on to say that appears, at the local welfare office. So I do not think that it's a very good idea to expect a person that is, you know, the welfare officer or whatever their title may be in that particular town to be responsible to make a determination whether or not a person in front of them is indeed showing symptoms or has, you know, symptoms of a opioid disorder, an alcohol disorder, you know, whatever that title may be. I really think that we are asking them to do something that, quite frankly, they should not be responsible to do. I don't know any welfare official that's a doctor. I know I certainly was not one, and I would not have liked it very much if I would have been expected to make that determination. I just don't think that, I do not think that's where it belongs. So respectfully, if the committee indeed feels that the policy that I think that they're trying to address, being harm reduction, is a good policy, and dare I say, I would ask you to amend it. I know what that's like when people come to your committee and ask you to amend something. I'm just respectfully requesting, if you do feel that that it is a policy and it needs to be addressed, wherever harm reduction goes in the RSAs that addresses that, I would humbly request that you put it in that RSA where it belongs. And if I may take your attention to line 13, it looks like it's section 2. You know, it says here, which may include payment of some or all treatments or service costs in other conditions mutually agreed upon by the municipalities, including limits on the number of individuals to be transferred, coordination protocols, reporting requirements. So is this asking that some people are going to be transported and some are not, because there's going to be a cutoff limit? That is showing concern to me of, well, who's going to make the determination of who receives care and who doesn't? What is that magic number? It seems like, is it going to be an arbitrary number? I'm not really sure, but that to me does raise a concern.
If you could please start wrapping up.
Yeah, absolutely. And the only other thing I would say is, Mr. Chairman, if I may, House Bill 348 that we passed out of the House, it did pass out of the Senate, does deal with local welfare. And as amended, that bill does have guide rails if the town does decide to adopt that you have to be a resident of the town. It does require that there has to be an intermunicipal hearing to determine exactly where the residency is of that person. But the bill in front of you does deal with harm reduction. So for all of those reasons, I would ask that you either amend it or don't pass it either way.
Just to clarify, you're saying 348 already addresses much of this? RSA 348 already addresses this stuff, or?
Mr. Chairman, RSA 3 or House Bill 348 doesn't necessarily address harm reduction measures. However, it does address that if a person is going to be receiving local welfare, that, and if they do not live in that town, that there's going to be a hearing between the two municipalities to exactly determine, you know, financial responsibility. The bill in front of you, I don't think it's right to ask, you know, local welfare, as you all know, is 100% funded by local tax dollars. There are no state funds whatsoever. So now we're asking local residents to be responsible for healthcare costs of an individual for, you know, for harm reduction measures. It just seems very confusing to me.
Thank you. Any questions? Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. Welcome to Health and Human Services. And thank you for your testimony, because in your experience, I wonder if you share my concerns about what happens in the small towns like mine and yours, where if a memorandum of understanding is supposed to be prospective and cover everything that come up, isn't it likely that the next thing that comes up in front of the local welfare officer isn't going to fit the memorandum of understanding particularly well?
I would agree with that, Representative Weber.
And as a follow-up, would it be a problem in your town, according to your knowledge, of having to figure out how to draft memorandums of understanding with all the various different receiving towns who might be receiving people who qualify for the services under this, but who might need to go, in our case, to Keene or to Hanover or to Manchester or to Nashua for specialized services. Would that be a burden?
I think that it would. Respectfully, I just think that there's a lot of, for as well-meaning as I do believe that the bill in front of you is intended, I just also see it having more unintended consequences, and it simply could be the way that it's written. And if you look through it, Mr. Chairman, I think there's 4, if not 5 or 6 different RSAs that are mentioned throughout this entire bill. So I don't know where you would start to figure out where it all belongs.
Thank you.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So are you familiar with, you heard testimony before about Mayor Jay and what the city and all these different things have had. The mayor had mentioned last year that other towns around the state were boasting they were just Ubering people to Manchester that had situations like this and issues like this. 2 towns specifically said they sent 5 to 7 people to Manchester with these issues. I think the question that I have for you based on that is the transportation side in the first section here. How would you address that in a bigger way? Because if we're not communicating with the towns, what's to stop them from dumping people with Ubers in Manchester?
So thank you for taking the question. I do believe that there's 2 different pieces here, right? So the very first line here mentions RSA 165. RSA 165 is local welfare, right? However, it goes on to talk about harm reduction measures and identifying harm reduction measures. That is not and should not be the role of a local welfare officer. I do know, however, last term, I believe, I do not remember the bill number. I remember there was a 0 and a 7 in it. There was a bill that passed, and it was signed by the governor to say that towns were able to basically request refunds, if you will. If a person is in a town receiving local welfare and they don't live in that town, that they could seek reimbursement from the town that they actually lived in. And the reason I addressed that was because it created a lot of confusion, because the person may not have qualified in their town, because you are allowed to set in guidelines, right? So at least with the new bill that hopefully gets all passed out tomorrow, that does address local towns coordinating with each other if a person is receiving local welfare. But are we ever going to be able to stop a person from being, transported? I do know it is illegal. It is in the guidelines of RSA 165. You're not allowed to just tell a person to go back where they came from, and you're not allowed to just, ship them off to another town. That is absolutely illegal, and it is. And if you look it up, it's under RSA 165A.
Follow up.
Those changes that you were just talking about, is that specifically the welfare, let's say offices that would be seeing those changes in the other bill?
The changes that I was referring to 2 different ones, Representative. One was the town's ability to request reimbursement from another town, but that is going to be addressed more, because it should be now where municipalities, if they choose, are allowed to say that they want a person to actually have to be a resident of that town to be able to receive funds. However, if they are in a town and they do not reside there, they still will receive relief, and the town does, and it is required that the town does seek to have that intermunicipal hearing to actually determine what is going to be the responsibility of what town.
Representative DeLamus.
Thank you, Mr. Chair. Thank you for taking my question. So if the person is homeless, how do you determine what town owns that person or that person belongs to? Just out of curiosity.
Well, first and foremost, I don't think that anybody owns I don't think a town owns anybody. That's not going to happen. However, within, and I want to be respectful to the chairman. He did not stop me when I touched on House Bill 348. And I want to be respectful. We are discussing the bill that is in front of us. However, it does address the fact that a person, if they do not live in that town and they do present, that they will be relieved. There's a period of time that they must be relieved. And then in that time, then the town does have to reach back out. However, where do they live? Well, if they live in New Hampshire, then they're going to have to be relieved from the town that they live. But I do know that Massachusetts and Maine have recently put in, they have changed their right to shelter laws. And I do know with neighboring towns, right, we're kind of like in the middle of this little triangle here. Respectfully, it's just not right to ask a person that lives, in Winchester or Claremont to be responsible for somebody that lives in Vermont or Massachusetts. That's just not, and how that is going to all work out. I don't know the specific answer to that, but I do know that local welfare is that. It's local welfare. The state does not give money for that. If they want us to, then perhaps that needs to be put in the budget. I know that I'm not going to be the one to do that, but it's just not the responsibility of local towns to be responsible. People don't even live in the state of New Hampshire.
Thank you.
Representative Weber.
Thank you. And as I'm reading through the current RSA 165, it appears to me that what the welfare that the town is required to do is kind of defined by what it isn't as opposed to what it is. It talks a lot about things like you're ineligible if you voluntarily left employment or left a program that was already helping you, for example. So could you help me by explaining, because my understanding is that general assistance is what you get after you've taken advantage of absolutely everything else that's available to you and you're still without some pretty basic needs. What kinds of things are normally done by welfare officers? I mean, the one I can remember was being told that tell people if they're out of fuel oil that might be a place that you could go. But what sorts of assistance are the usual things that a welfare officer would be dealing with?
Thank you for your question. So first and foremost, it would be the best of all worlds if the person did already exhaust all of their other options. Unfortunately, that is not what I found when I was the local welfare officer. And I do know that I worked with Mr. Marsh a great deal. He was very kind to answer every phone call that I made because I really just didn't even know what I didn't know. And one of the things that you find is people unfortunately do not take advantage of all other options. So your job as a local welfare officer, one, is to direct them to all those other options first. However, most what I saw were people that wanted rental assistance or like you're saying, help with fuel. And then within that is where you would set your guidelines. And that's where I was saying some people may not qualify in that town, right? Some towns allow for you to have a minimum of a car payment, right? You need a car to get back and forth to work. Some towns thought that was the most ludicrous thing in the whole wide world, right? So that is what would make a person either not qualify or to qualify. But I would say rent would be very specific. Fuel would be another one. Sometimes a person, their electric was turned off and it wasn't for lack of not having funds. It was because they didn't pay it or they just, forgot to pay it. There would be a lot of food vouchers that may be given out. But most towns that I know of, have, like donation sections. I know we had that in our town and that was something that I just managed was, that stuff that was, people were kind enough to donate.
Other questions? Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. Thanks for bringing up the harm reduction piece because was very involved in the writing of the definition of harm reduction in this state. We went to a lot of effort to do that. And it's an interesting question you raised, but and I'm curious what you would think about this, because in looking through this bill, I'm struggling to understand the inclusion of section Roman numeral 4, Roman numeral 5, Roman numeral 6, and the entire section 2 and probably section 3, because I think it really diverts from what they're trying to accomplish. And as far as I know, municipalities can already do those things, and they're mays, not shalls, and I think it kind of distracts what the whole purpose of the bill is, and I'm just curious what you think about that.
Thank you, Representative. I think I also am very confused. I don't want to be rude or disrespectful, but looking through it, that's why I said there are multiple RSAs that are mentioned through here. But it very much starts out with RSA. It wants you to amend RSA 165. RSA 165 is local welfare. This bill, at least my understanding from the testimony from the sponsor, is dealing with harm reduction. I don't know where harm reduction goes within the statutes, but I do know it is not RSA 165.
Okay, I'm seeing no other question. Representative Polazov.
Thank you, Mr. Chair. Thank you for taking my question. So one example we heard is dropping people near shelters that is out of capacity or during the hours when it's unable admitting people. So if shelter provides housing, does it fit the definition of chapter 165?
I'm sorry, what was the question?
One example was providing shelter, housing assistance.
Yes.
So does it fit definition of chapter 165?
RSA 165 does deal with providing temporary shelter, yes. So if the person appears in front of the local welfare office, the very first thing that you should say is that you need to reach out to the local shelter. If it indeed is full, then obviously you would, is their friends or their family. And then if that is all exhausted, then local welfare officers do have options available to them. Generally speaking, it's going to be a hotel.
Follow up.
Just seems that at least that portion is well placed in 165 because dropping people at shelter in the next town seems like qualify with the same activity. Would you agree?
RSA 165 does deal with shelter. So if a person appears and shelter is what is needed, then that would be the responsibility of RSA 165, if that is your question.
Okay, Representative Hartnett.
Thank you, Mr. Chair. Thank you for taking my question. If this is really about patients being dumped one jurisdiction to another, do you know of any town or municipality who has refused to engage in a good neighbor way with another town or municipality on this subject?
Well, thank you for the question. The way the law is written now, you are not allowed to refuse a person local welfare if they are present requesting it. You must come up with something.
Follow up.
Yeah, we're looking to create a statute here. And I'm wondering, short of a statute, whether you know of any evidence of, towns who abut one another have refused to talk about finding another solution to this problem, because apparently it's of such scale that it requires a bill.
Well, we do have statutes that address it. We have RSA 165 that is very detailed on local assistance. Within that local statute are guidelines that towns are allowed to make. However, there also are laws in RSA 165 that specifically say that that a town is not allowed. It's basically illegal to refuse a person assistance if they are not a resident of your town. So that is absolutely covered. The bill in front of you is not, the bill in front of you is referencing the local welfare statute, but it is not dealing with local welfare. It's asking the local welfare officer to be responsible for harm reduction acknowledgement. So I don't know where harm reduction goes, but I know it's not on RSA 165. I'm certain that people do appear in, Manchester, especially that's where a lot of services are. I know that people appear in Keene, right? And that's what I was mentioning to the representative over here, was there was a law passed last year that allowed towns to seek reimbursement from the town where the person actually lives if they were indeed, taken and left for better or worse. So those things are absolutely addressed. They're addressed in great detail. They are. I mean, they are. Look up RSA 165A. They are absolutely addressed, and I'm certain that the people behind me that deal with this as professions can attest to that without a doubt.
I'll move on.
I'll set.
Okay.
Representative McLean.
So, thank you, Mr. Chairman. Thank you for taking my question. So, Tim, so just to clarify, so you say under RSA 165, the receiving town cannot refuse. But is there anything in that that says it is prohibited from just going and dumping people without notification? Is that covered in that already as well?
It does say in there that you are not allowed to refuse a person a service, but you also, if the service is provided, are allowed to seek reimbursement from the town that they lived. However, if people are being quote unquote dumped, then the way it was addressed in House Bill 348, which is why the chairman was kind enough to let me bring that up, then the hearings, the intermunicipal hearings, which is basically what this memorandum of understanding is addressed in House Bill 348.
So just a quick follow-up. So I just would like to, like a specific example, we had the Manchester police chief, and he referenced a case where two Londonderry police officers took a person from Londonderry and just dumped them in Manchester, and they were caught red-handed on it. It was on the news. He was very not happy about it. So under 348, how does it speak to that incident, to prevent that incident?
It is already illegal to just take a person because you don't want to deal with them. That is already illegal to do. That's illegal.
So that, and do you know what statute that's under by any chance?
165.
That's it. That's in 165.
Yeah. Yeah.
Thank you.
Okay, before I ask for any other questions, Representative Palazzo just reminded me we're in the lunch period. So if any members do want to go to lunch, we're probably not going to take a formal break, depending on when this hearing ends. So we'll continue at least until the end of this hearing, and the next one is at 1:30. So anyway, any other questions for Representative Rhodes? I'm seeing none. Okay, thank you.
Thank you, Mr. Chairman.
Also signed up to speak Jenny O'Higgins and Attorney John Williams from the Department of Health and Human Services.
Good afternoon. For the record, I'm Jenny O'Higgins. I'm the Legislative Liaison for Behavioral Health at DHHS.
And with Jenny is John Williams. I'm the Director of Legislative Affairs.
So you have already heard lots about the implementation of this bill. DHHS is not taking a position on this bill, but is here to provide lots of information on different fiscal and operational impacts. So as you've heard already, the proposed legislation would require municipalities that are transporting individuals for housing, shelter, or substance use disorder treatment to have MOUs with the receiving municipality. It would also allow municipalities to set criteria for harm reduction messaging and distribution. And I know Representative Nagel has already brought up the fact that there are actually two places in this bill that are under the opioid abatement trust fund statute. And so the stipulations around the criteria or the prohibition of those services would also include both syringe services programs as well as anyone funded by the Opioid Abatement Commission. This does also, the MOUs also has the imposing of a $5,000 fine on municipalities. So I know we've kind of already been through a lot of this, so I don't want to be too repetitive. I do want to make sure that we're really clear around the pieces that impact DHHS though. So the bill, DHHS does not have any existing authority or staffing or systems to perform any of these functions. We don't currently, oversee any municipal types of activity in this way and don't collect these types of fines or have MOUs between two different municipalities. So with more than 300 municipalities and no already existing authority or staffing for this, that's sort of the fiscal note that you see on there is us saying, if we were to do this, if we were to figure out how to implement this, which today when we read this bill, we are not sure how we would implement this. It's not something that seems particularly workable, but if we were to do so, we have an estimate for compliance officers and IT system, all these different things in order to track and then implement those fines. So those are some of the fiscal note implications that was asked about earlier. Has the estimates of the staffing as well as the IT system development and the having an annual operating cost of those pieces. That's what you're seeing there in that fiscal note. Additionally, to go back to that opioid abatement piece, we have the potential prohibition of syringe services, which you've heard us speak about already on another bill in HHS this year. And then the additional piece around those organizations funded by opioid abatement trust funds. So that could include recovery community organizations or housing and things like that. So it actually opens it up to a pretty big number of potential places that could be impacted. And the commission, this is not where that's placed in that statute, is not aligned with the commission's purpose or authority or regulatory responsibilities today. So there are some pieces in here that we feel like are technical defects of the bill that could be really challenging. Additionally, it's unclear to us how the proposed legislation may impede access to the services for the individuals, because it does say the MOU needs to be in place prior to transportation, and if an individual is in need of that health care for substance use disorder treatment, today those services that are provided, some of the examples that have come up already in testimony include community mental health centers and doorways. The services could also be hospitals and shelters, and many of these organizations are required to serve everyone. So the doorways today there's 9 of them. There's not 300 like there are municipalities, right? There's not a doorway in each municipality, just like there's not a hospital in each municipality. And so we're unclear in terms of in this bill how the bill may impede services, people having access to those services. And so given these, substantial kind of fiscal and operational challenges with this bill, we wanted to make sure you had some understanding of the difficulty that would exist to implement and the cost potential if we needed that additional staff, and then as well as some of those mechanical challenges of where in the RSAs those things are being placed. And I'll hand it over to John.
And keeping the afternoon very brief here, because we are pointing out the problems, we also come seeking solutions for you for your consideration. What I am going to be handing out is actually an amendment that the Senate Health and Human Services Committee actually passed, and it was an amendment that took the department out of the equation because they understood our testimony that although we're not taking position on the underlying bill, that this is not something that we would do as an agency, and if we are required to doing it, we would need the resources to making it happen. I have brought to this committee before those type of amendments that would push out the effective date to the next biennium, but also additional safety valve language that says we don't have to do this until it's sufficiently funded. But I thought for the committee's consideration, it'd be helpful for you to see where the House Health and Human Services landed on this particular bill. There are other speakers that are coming after us for around the municipalities, and those folks may have additional thoughts. So we're not taking a position on this amendment, but it does resolve the fiscal issue that's incredibly important.
There, the top is, yeah.
And for brief clarification, the bill as it came out of the committee was amended very close to as it was introduced, and that's why the fiscal analysis reflects the cost that Ms. O'Higgins was just referencing. You've heard me mention, and this is something that the legislature cares. And with that, we'll take questions.
Okay, Representative Weber.
Okay, thank you, Mr. Chairman, and thank you for taking my question because I've completely lost the plot here. So could I ask, first of all, because I haven't seen the amendment, all I have read is the thing that's in front of me. Am I wrong in thinking there's nothing in here that requires the Department of Health and Human Services to do anything? This is memorandums of understanding between the towns, is that correct?
Okay, so the bill as passed by the Senate in front of you requires the department to do quite a few things,
Okay.
including the enforcement mechanism, so that if there's a dispute between the municipalities and also the fine considerations, the MOU part, we are actively involved with having to administer. You know what? I'm gonna hand it over to Ms. O'Higgins because lunch is awaiting.
Well, just if you look at page 2, lines 1 through 3, you'll see that if a municipality is found in violation of this subject, they'd be subject to a fine, and the fine is payable to the Department of Health and Human Services.
May I have a follow-up?
Oh.
I don't mean to interrupt you if we're going to say more.
That's
But
okay.
my follow-up is, that's just that small piece at the top of page 2, and I get that, but that's just collecting a fine. If am I wrong in thinking that the memorandums themselves are negotiated town to town without the intervention of the Department of Health and Human Services?
Yeah, the rules fall under the Opioid Abatement Commission, which is administratively tied to the department. So where it says that you need to make rules regarding the transportation of these individuals is actually under Opioid Abatement Trust Fund. So that falls into the department, and the fines fall to the department. And so we make an assumption based on the fact that we actually don't think this is mechanically workable today. We're making an assumption that these MOUs and the oversight of them fall to us, since the rulemaking for the MOUs would fall to us.
Okay, so one more follow-up. So I am also bewildered as to why any of this has anything to do with the Opioid Abatement Trust Fund. Because am I wrong to have been thinking about this as a solely municipal to municipal issue? And why does it have anything to do with the Opioid Abatement Trust Fund?
We're just here to point out that technical mechanical defect within the bill. We don't know how that came to be.
Okay. I'll let other people ask questions and maybe I'll come back at the end.
Representative Nagel.
Thank you, Mr. Chair. Thanks for taking my question. You and I really got to know each other well over harm reduction issues, so I know you're so much smarter than I am. And I'm really struggling to understand section 3, section 4, section 5, and section 2. I mean, the Roman numerals 3, 4, and 5, and then section 2. Can't municipalities already do that? It says may, not shall. I mean, we're not telling them they got to do it. I just don't even understand the point why that's even in there. And then the second thing is then now that, like you say, by having that in there, that now creates oversight by you and us that we don't actually do now. That creates a logjam of problems. Can't you just eliminate all that stuff?
Again, it's just not a department requested bill or something that we worked on the language for, so I don't really have the answer of the intent for those sections. However, I do agree with you that I find them confusing, especially in where the Opioid Abatement Commission is named in page 1, lines 21 through 24, because that again would be all the different organizations that may be funded, and that could be many types of organizations and or municipalities. So it would be pretty confusing in terms of implementation.
And also, just a brief follow-up, Again, this is not a department requested bill. We are here as a resource and not taking a position on the underlying bill. But as you've heard testimony, and I thought that Representative Rhodes' testimony gave you some guidance that if a bill has some difficulty, perhaps considering other options versus passing the bill that's in front of you, that's where we're trying to give you an option to looking at the amendment that was actually passed out by your counterpart. There were 5 members, and you have more members here, which means that more gray matter on looking at it. But just briefly stated, and this bill is not obviously on the amendment, but for Representative McDonald, if I could just briefly walk the committee about what the amendment did and why they settled on it. And it gets to Representative Weber's point of, isn't this just about a memorandum of understanding? And that's actually why in our testimony before this committee and before the Senate, that this is a municipal issue in terms of having the department getting directly involved with being the negotiator, rulemaker, and enforcer of it, that the legislation that was worked on from the committee, as you'll see here, it adds under RSA 161.5:2A, which talks about the financial responsibility, general assistance provided to persons. It breaks it down for Romans 2 and goes all the way through to the following page about the actual process, trying to keep it simple. And it refers to the towns as 2 parts. One is the municipality of residency, and the other one is the assisting municipality. So it gives them a very clear, open guidance in terms of how to resolve those disputes. And they would get a third-party welfare administrator who's willing to act as an arbitrator to negotiate any disagreements that might be between municipalities for setting forth those repayments for assistance. I do think that Representative Rhodes brought an incredibly important part of the conversation that you already have coming out of this committee and has been passed by the Senate, true with an amendment, House Bill 348, that at a minimum, somehow there will need to be some reconciliation if this bill is moved forward out of this committee with that particular bill and how it meshes up. I try to do the quick crosswalk as like an OLS attorney on the fly, and it did look like there were some complicating issues between that bill and the legislation in front of you. And again, this was meant to be offered as an accommodation that if you are inclined, because we're not disagreeing with the underlying intent and purposes of the bill, but if you are intent to passing it, please make this so that we're protecting the state's budget that currently has been adopted on core issues and missions, not only from the legislature, but from us in the executive branch. And we not only have to be thoughtful because the impact starts in this coming up state fiscal year in 27, but also in the future budget, that this is taking on an additional resource already beyond that which you thoughtfully put together a very hard worked on budget, and it's going to be a hard worked on budget the next session as well. So we're really asking for your consideration for other alternatives if you are planning to pass this bill out of the committee.
Representative Lamontagne.
Thank you, Mr. Chair. I just want to clarify that this amendment was drafted in the Senate committee, but then it did not pass.
It was recommended ought to pass unanimously by the underlying committee. As we know, bills go through the process, and by the time it made its way to you, it was amended back by the full Senate, and this is the Senate position, clearly, but it was amended by the Senate pretty much as the bill was introduced, or very close to it.
Okay.
Representative Weber and then Representative McLean.
So am I reading the docket correctly that this is more as the bill was originally introduced? Sorry. The bill was introduced, the committee adopted this amendment, the whole, it looks like, am I correct that the Senate adopted this amendment by a voice vote, but then there was a floor amendment that changed this to what we see in front of us?
Correct.
Okay. So it's the department's position, am I right, that what you handed out, which was the Senate Amendment 841S, is something that would be easier for the department to administer than the bill as passed by the Senate? Is that?
And with a level of clarity, without taking a position on
Right.
the underlying bill, this was based upon our agency's discussion with the policy committee, and it got the department out of the mix and left it to municipalities to
Okay.
determine how to resolve those disputes.
Gotcha. Okay, thank you.
Representative
very helpful.
McLean.
Okay, so I'm drinking from a fire hose because there are so many moving parts here. So I apologize, and I'm just gonna jettison a lot of it. And I just want to kind of get to the heart of something from my own understanding. The prime sponsor said that, you know, if there was a full capacity in Manchester, their approach would be to have them go through doorways. My first question is, and maybe the chair will indulge me with a follow-up, are there certain doorways that are overutilized and certain doorways that are underutilized that we could leverage them better? So that's question one.
So I would say much like our healthcare systems, we have greater populations in certain regions of the state. And typically those regions also have additional resources that wherever we have, you know, more of a population, we also have additional resources. So the doorway in our urban regions are going to see more clients than in our rural regions, and they're resourced to do so. And they don't necessarily have, when the way that the doorway is talked about is, do they have room? That was about I would make an assumption that that's about specific like respite care if someone needs somewhere to sleep overnight. But the doorways are open for all clients. And not all clients need respite. So there's not like a time where a doorway is full.
And and again, this is because I'm three different parts. I'm just trying to understand, would a more elegant solution possibly be, rather than having MOUs and getting into all of this, just to require agencies to go to the doorways first instead of second? Would that be workable? Would that not be workable? Because this is getting very complicated. And so what are your thoughts on that?
Before Mr. Higgins responds, that actually, we will respond, Chair, but it really goes beyond the scope of the legislation and the problems and concerns of the bill that's actually in front of you. So I would imagine whatever our response would be and whatever tool you'll try to remedy would, at a minimum, assuming all the stars perfectly align, at a minimum would be needing a non-germane amendment to be brought forward on this bill. But I'm at this time turning it over to Ms. O'Higgins, and at a risk trying to again, not taking a position, but I think we've identified the concerns that we have with the current legislation.
So that I don't know that in every instance that's referenced in the bill in front of you, that the doorway is where the person needs to go, since it also is for homeless individuals, the person may need shelter, this kind of thing. And so I don't think that that we overall can determine an individual's need in that way. So I wouldn't say that, you know, this is the first stop versus this other thing.
So it's not a kind of catch-all then? Okay.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. I just have, I mean, I can sum it up into two kind of parts. On the back of the current bill that we're looking at, there's two sections. One is about the operation of the syringe service program that Representative Weber pointed out in that line. It looks to me like most of that service is paid for by opioid abatement funds in a lot of municipalities, if I get that correctly. So is that something the department already has to oversee?
All syringe services programs have to register with the department and have to submit data to the department. They are funded in a variety of ways. Like many other types of nonprofit entities, they may do some of their own fundraising. They also do receive opioid abatement funding sometimes, as well as governor's commission funding or general funds. So there's a mix of funding for those programs. It's not all under one specific type of funding.
Follow up.
I guess just looking at that one specific thing, would we still need to have rulemaking for that, because we're allowing in this other bill let's say the towns to make deals? You're basically sidestepping with the amendment what we already have in current RSA. So there needs to be some kind of rulemaking, it looks like to me.
It exists. So syringe services has rulemaking. It's that rulemaking is already existing. So what the bill is asking is to add requirements under that, the RSA 165, relative to the operation of syringe services programs within the municipality, which would be in addition to existing rulemaking for syringe services programs. You
Just
can
a
clarify
clarification.
if I'm misinterpreting it. Okay.
I'm just saying, I'm looking at the amendment you handed out without rulemaking. Is there an additional requirement that we're gonna need to make sure those towns don't overstep their authorities? To, when it talks about giving money to each other and communicating what expenses? I'm just asking.
Okay, so just parsing things out very carefully in response to the question and making sure that we're understanding it. The amendment that was passed by the Senate Health Policy Committee completely takes the department out of the equation. What Representative Kesselring, my understanding is by implication, is this language, even though you're not stated in here, because the MOUs could affect the syringe service programs, would it still require us to be brought in to perhaps amending or modifying our rules based upon those MOUs? And I will turn it over to Ms. O'Higgins now that I think I understand the question, but I think anything is possible. And I think certainly there could be some duplication of effort, but certainly not as sizable as the bills that came in terms of the complicating issues and the funding issues of the bills it actually was passed versus the committee amendment by the Senate.
So I'll just add that unless I'm misinterpreting the intent of the bill, the syringe services pieces are completely separate from the idea that a municipality has some financial responsibility to another municipality because their resident receives treatment there. I don't see the syringe services part as related to the intent of the bill.
Go ahead.
Just for clarification, this might be an intent issue that why the bill got passed in the Senate this way, because those two outlined sections there that are darkened could be things that municipalities are concerned about. I don't know that's the answer. I'm just saying I'd love clarification if you feel that these things would be covered under that, if there's any other thing. You don't have to give me an answer now, but I'm curious because it does seems like we're opening a problem that if they're saying these are required in this one section, but we're doing the changing the amendment here, feels like this is still going to be an overlapping issue. So.
Okay.
Yes, we would believe.
One last question. Go ahead, Representative Delamus.
Thank you, Mr. Chairman. So I'm going to refer back to RSA 165. There's a problem that needs a solution. The dropping off and dumping of people from one municipality to another. Do you feel that RSA 165 is a solution to the problem, and should it just have more teeth, or what we need to come up with a solution? What would your suggestion be?
Well, I don't know that this is always, I think we would need additional data to truly look at this concern that's been brought to us, because I don't know if there's always the idea of this dumping or leaving people in other cities. Sometimes people are asking for treatment, and the treatment exists in that other city. So in that, the same that I don't live in Manchester, but I receive all of my health care in Manchester, right? So if there are not services in the town in which I live, and I ask to be voluntarily transported to the town where there are existing services, that's a complicated issue. I think asking the questions around, does the municipality end up having any financial responsibility for that, is more complex than what this existing bill would be able to solve.
Follow on.
Thank you, Mr. Chairman. So, if you have the person that is not asking, let's just say, we'll take the example of the person who was passed out in one place, picked up, put in a cruiser or whatever, and then just simply brought to another place, wakes up and goes, oh, how did I get here? How do you handle that?
And certainly, Ms. O'Higgins, in response and substance to your question, we work very collaboratively, but we are the state. We are the Department of Health and Human Services. Right. And the provisions of law under Chapter 165, even though they interrelate to helping the same citizens that we all help, are those of the municipalities, not of the department, which is why we pointed out this is not the department should not even be being brought into it. I think people think we do a lot of good work, and I think that's how we unintentionally got named as the tag you're it on the bill. But clearly this is a municipal discussion, and my understanding is you may hear from folks from the municipal association or others who might be in better position answering those questions. As far as a transportation issue, it's beyond the scope of our agency.
Thank you.
Okay, I think that's it. Thank you.
Thank you.
That was awesome. Couldn't even get it all.
And speaking of the, I believe that's what NHMA stands for, the New Hampshire Municipal Association, Sarah Burke Cohen.
Hopefully she's got written testimony.
Doesn't look like it.
Oh, dear.
Good afternoon. My name is Sarah Burke Cohen. I represent the New Hampshire Municipal Association. The New Hampshire Municipal Association opposes this piece of legislation for several reasons. Firstly, memorandums of understanding can already be entered into by municipalities. And I think that if you add additional statutory language relative to a memorandums of understanding in statutes that don't seem, it seems misplaced, that that's going to be problematic and confusing. The other, issue is certainly it's a mandate, number one. Number two, municipalities, there could be some confusion when it comes to local welfare applications. We talked about work on, or Representative Rhodes talked about work on another piece of legislation to address some of these issues about residency of individuals being transported to other municipalities. And I think if this bill were to pass as written, as well as the other bill, it would become very confusing on who's entering into memorandums of understanding and who's not. Are municipal law enforcement entering into these memorandums or not? The other issue certainly is the timing of it. Memorandums of understanding generally are entered into by the governing body. So this could be problematic if we're looking at trying to get seek services for someone in an emergency situation. I need to transport this person to this so they can get services for either shelter, homelessness, or addiction services. You'd likely have to have a governing body approve that, or a governing body who has delegated that authority to, I suppose, the chief or the the local welfare officer, which would seem like something that wouldn't be done because we're talking about an intermunicipal memorandum of understanding, and I'm assuming the governing body would want to have some say in that. The other thing certainly is, it's been touched on, is requesting municipal employees to try to determine whether someone is having, is addicted to an illegal substance or some sort of substance, and what that looks like. Addiction is different for everyone. What happens if that municipal employee makes a mistake and says, oh, that person's not addicted, and they are, or the other way around? I think that becomes very problematic. The other issue is we're talking about, I know there were questions about how often is this happening? What are the statistics on this? I don't think there are any. I know when the Manchester chief testified in the other chamber, he had brought up only knowledge of 5 events that happened in that municipality within the last year or so. So there are no real statistics on this. Which makes compliance kind of problematic because what is compliance going to look like? So I think that there's a number of things that are problematic. To touch on the,
If you could start wrapping up, please.
I'm going to right now, to touch briefly on, I know paragraphs 4, 5, 6 to the end essentially have been brought up. Those are problematic by virtue of, I don't think they belong in 165. 165 is about assistance for local welfare assistance. These seem to talk about harm reduction. That doesn't seem like something that should be in that, intermixed into that statutory scheme. I'm not sure exactly where it should go. Maybe it should go where health officers are have the ability to give to put local regulations in place, but I don't think 165 is the appropriate place, and I'm happy to take questions.
Thank you, Representative Weber.
Thank you. And thank you, Mr. Chairman, and thank you for taking my question. Isn't it true that substance abuse treatment is not normally dealt with by welfare officers, and that the payor for substance abuse treatment if there aren't any other resources is not the town, but Medicaid. Is that right?
That would be my understanding. I will tell you that the representative from the New Hampshire Local Welfare Administrators Association has put in a pink card as well. So I would say that might be a better question for him to talk with you about.
Okay, thank you. I'll
Mhm.
reserve that then. Thank you very much.
Other questions? Representative Nagel?
Thank you, Mr. Chair. Thanks for taking my question, but this is a somewhat cynical question. So what we're talking about is spending nearly $1 million to solve a problem that affects 5 people.
I'm not sure how you, I mean, I hear what you're saying. That is what the fiscal note says. And that was the statistics that were offered by the chief, because there are no true statistics about what's, whether this is happening on a large basis, but his recollection was that there was 5 individuals. So yes, I hear what you're saying.
Just a follow-up.
Follow-up?
So would it make more sense to actually spend a little time studying the issue to find out how prevalent it is before we commit to spending $1 million?
I would agree with that.
Representative Hartnett?
Thank you, Mr. Chair. Thank you for taking the question. Question about your membership. Do any of the municipalities or towns, do you know any that would be opposed to establishing, independent of this bill, some kind of good neighbor MOU independent of this? Do you know of any that would be opposed to that?
I guess I would have to see what that looked like.
It's just the negotiation of it. In other words, hey, can we talk?
I'm hoping our municipalities, and many of them already do that.
Any other questions? Seeing none, thank you.
You're welcome.
I'm going to step out for a little while and to turn the chair over to the vice chairman, Representative Mazur.
Opportunity. Okay. Next we have Todd Marsh, the New Hampshire Local Welfare Administrative Association. Welcome. You indicate, yeah, and we have 3 minutes. You good?
Happy pre-lunch afternoon. As was indicated, my name is Todd Marsh. I am the welfare director for the city of Rochester. Rochester does have homeless shelters. We do have substance use disorder centers. We do have a hospital, etc. However, I am here today as president of the New Hampshire Local Welfare Administrators Association. We oppose SB 441 as amended in the Senate. The association appreciates the work to narrow the bill, including the clarification. I think this is important and a very important clarification here, as I've been listening, that the MOU as written indicates that it is unrelated to a person's request or application for local welfare general assistance. And that's the primary concern that we have as an association, as a welfare association, that we do appreciate the bill indicating that it doesn't relate to local welfare. However, it still stands in RSA 165. It is still being housed there. And that doesn't make a lot of sense to us. We have indicated that if the committee or the sponsor wants to move forward with the bill in some form, it makes sense to be in some other RSA. I very recently reached out to Senator Sullivan. When I say recently, I mean yesterday, and suggested some other RSAs that it could potentially be in. I certainly can forward those RSAs to you as well. However, it simply doesn't make sense for a bill that's excluding local welfare, and we think it makes sense that it does exclude local welfare, to be housed in RSA 165. We believe that it would cause confusion to welfare officials throughout the state, especially newer ones and people and welfare officials in smaller towns. So also, I think it's important to clarify that the amendment that was provided to you by DHHS is now currently in HB 348. That's what happened. What happened was, and I've been following this for a year plus, as you might imagine, there were two lanes for this language, right? For the municipal for the intermunicipal hearing language. One was 348 and one was 441, right? As discussed in the committee. It passed the committee. However, the chair and committee members in the Senate believed it was better housed in 348. That language is better, was just a better lane for it. That's what happened in the Senate. And once it was either tabled or it was about to fizzle out, Senator Sullivan resurrected it, and that's what you see in front of you, right? The language that was currently in front of you for the amendment from DHHS is currently in HB 348. Also, although to another point, and not our primary focus.
If you could just start wrapping up.
Absolutely, yes,
Thank you.
yes, absolutely. We are concerned about the language indicating that the municipality would be expected to determine symptoms of addiction. As was indicated, that's challenging for people that don't have that type of experience. And what if we get it wrong? What if it's a medical condition? What if the person's not presenting at community A, but presents to have a substance use disorder, to have symptoms in community B? Will community A be fined for getting it wrong, potentially? So we believe, in wrapping it up, we believe that the primary issue for us, for a welfare association, is it's in the wrong lane. It's not housed in the appropriate RSA. And secondary is that language regarding municipal employees trying to determine if somebody has a substance use disorder in front of them. Welfare aside, because again, this is not a welfare, it excludes welfare. And so we think that this, at least at the very least, deserves some additional review by your committee.
Thank you.
You're welcome.
Yes, Representative LaMontagne.
Thank you, Madam Chair, and thank you for taking my question.
You're welcome.
I was curious about that language in there, unrelated to the person's request or application for general assistance. But to me, that read, well, if a person is, they're saying like, if they're applying for other assistance, it shouldn't matter whether we refer them to get services. But I'm just curious, if someone does come to your office for assistance and they say they have a problem with substance abuse and they need help, you would refer them to a local place in Rochester. Is that right? I mean, how do you help people? And if you don't have enough places, wouldn't it, say another town, wouldn't the office for assistance send them to wherever they can get help, even if it was outside of the municipality?
Yeah, I very much appreciate the question. So in Rochester and in the vast majority of municipalities across the state, they do look local first. It just makes sense, right? If that substance use disorder center is in town, it just makes sense for the person to go there. And then we start reaching out, okay? And I think it's important to also be mindful, to your other point, that in the current law, in the current RSA, a substance use disorder center does not constitute residency for local welfare purposes, right? Or a homeless shelter, or a hospital, or a corrections facility. I suspect Concord appreciates that, right? So if we do refer a person to a substance use disorder center in Manchester, okay, it would be a warm referral. We would make sure that there is a spot, that there is a place, a placement for that person. We wouldn't just send them willy-nilly, so to speak, and say good luck. That's not helping. That's not service. But while the person is there, they are not a resident of Manchester. They just happen to be receiving assistance from Manchester, just as if they were in a hospital. And I will add that the New Hampshire Welfare Association does have a best practice guide regarding placements, including when to look outside the area and when not to.
Yes, but before you do that,
I have to quickly step away. Representative McLean, can you jump in this spot real quick? Just for, I will be right back. I have been called to another committee quickly, kind of multitasking today. Sorry.
That's,
for the
it's
interruption.
dwindling, but that's okay. I won't take
Thank
it
you.
personally.
We have just one left. Thank you.
Thank you.
Thank you.
Sorry
Oh,
for the interruption. I'm sorry for interrupting. Just a second. Could you repeat, you had said currently your welfare doesn't have involvement in the, helping people who are addicted?
Well,
Or who need to go to another municipality?
so based on the current law, we don't necessarily have involvement in recovery, but we may have involvement with transport. Right? If someone approaches us and we can't get them into a local facility, they may ask us, can you provide an Uber? And I will say this, very, very rare. The vast majority of the time, it's a nonprofit. It's a nonprofit that's assisting with transportation. It's rarely local welfare. But if it is local welfare, for us to do it, we would verify that there's an actual placement for the person where they want to go, so that they're not just dropped off at Cumberland Farms and we're crossing our fingers.
Yeah, I just wanted to understand what your role is. But the local welfare office would say, okay, you need help, you need treatment, and you don't have health insurance. We will help you apply for Medicaid as a resident of your city, and so that will help pay for your treatment. Is that what happens?
We could do that. The current law does not indicate, that's not an obligation for local welfare to case manage in that way. However, in Rochester we do, and I will say that in many communities across the state, they are increasingly doing that because it just makes sense, and it's also cost effective to help people apply for services and not just be the numbers people in local welfare. I think of myself as, and I respect accountants. However, I'm not an accountant. I'm a social service person, right? So the numbers matter, the budgets matter. However, if someone approaches us and they need assistance with applying for Medicaid, it certainly is the right thing to do, and it's the cost-effective thing to do.
Okay. Yes, Representative Weber.
Thank you very much, Mr. Chairman, and thank you for taking my question.
Thank you.
I'm still trying to find where it says that these are not services that are general welfare services, or is it just that these are not services that you normally do at this point? I thought you made a reference to a specific point in the statute, and if so, if you could point it out to me, that would be really helpful.
Absolutely. So, in the statute, in the proposed bill, it indicates that the bill.
Does it?
Quote,
do you have a line number?
I should. Yeah. That's what happens when I copy and paste. It's towards the beginning. What was that? Page 1, line 8.
Okay, I got
Thank
it.
you very much.
Okay, thank you.
You're welcome.
Thank all of you.
Yeah.
No, I think
It's
I'm
a
all
community
set.
effort, really.
So I just had a question then, if nobody else has a question. So, you testified that 348 kind of, which I thought was actually like a living bill, that it's gone. But that much of that was incorporated by the prime sponsor into this legislation?
The opposite. Right.
The opposite,
So,
okay.
but you're close, but just
Okay.
the opposite. Right. So there were this language, the language that was presented to you from DHS, the amendment language.
The amended language.
The amended language regarding intermunicipal hearings, that came out of the 441 committee discussing 441. However, at the same time, it was also in a bill for 348.
Okay.
And so it passed the committee, as was indicated. It passed the committee for 441. And then when the committee chair realized, I can't speak for the committee chair, but from my perspective, when the committee chair realized oh, this language is also in 348, and that's just a better place to house it. The committee chair was on the committee, the other committee, the 348 committee, and voted for it to be in 348.
Okay.
Instead of, so they tabled or some 441 for it to be in for it to be in 348, this language, the intermunicipal hearing language. And then Senator Sullivan sort of resurrected the previous language that was already in the committee, and it passed the Senate. So the intermunicipal hearing language is currently in 348, which I believe will be voted on, which passed the House, the Senate recently, and it should be voted on, I believe Senator Rhodes indicated tomorrow.
Okay, so if you were to look at amending this at all, you would want to take out the reference to 165, find a new home. You would want to get rid of all the reference to on line 7 and 8, you know, person showing symptoms, things of that nature, and you'd probably get rid of everything on the bottom of page 1 and all of page 2. I'm just trying to get a broad understanding of what works and what doesn't. Is that kind of where you're thinking of going if we were to look to amend the bill?
I appreciate the question. I think my marching orders from our association,
okay,
right, who may be listening right now, right, at least some members, is primarily this isn't the right place to house this. 165 is not the right place to house it.
Okay.
We have concerns regarding municipal employees, even though they may not be welfare officials, because we're excluded from this.
Okay.
So we're thinking more broadly, right? Making those determinations whether or not someone is experiencing a substance use disorder. We do have some thoughts regarding other areas of the bill. However, I want to be careful giving you those type of opinions without.
No, I appreciate that, and I was just trying to get a feel for
yeah.
broad scope. So I
Absolutely.
appreciate that, Representative Weber.
So, and you can decline to answer this if it's outside the scope of what you were told you were dealing with here. If I'm looking at the docket of 348 and I see that it passed the Senate at the end of March, so it's already done, it's just ready to go to the governor. Is it your opinion that 348 is passed, is adequate, and you don't need this at all? And if that's not something you want to
Yes.
answer, that's outside of...
Yes, and I say that because our association assisted with drafting 348.
Okay. Okay, thank you very much.
You're welcome.
Yep, I'm good, thank you.
Anybody else have any questions? All right, thank you very much.
Thank you. Have a good lunch.
All right, we have one more. We have one more pink card.
Sorry about that.
And yes, and I'm sure he's going to give us lots of great information. Jake Berry from New Futures. And welcome to the HHS Committee.
Good afternoon, representatives. I will try and be brief. I think I'm the last thing keeping you from a very brief lunch. My name is Jake Berry. I'm the Senior Vice President of New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for nearly 30 years to help address substance use and behavioral health issues across our state. I don't want to repeat too much of what's been said here, but I do want to express our questions and concerns about this bill. Much of our time this afternoon has been spent addressing the MOU provisions of this bill, and rightfully so. We do share many of the questions and concerns around that. Specifically, what will come of individuals who will engage with police or municipal officials who are in need of treatment? How will they be connected to treatment if there is not an MOU in place? And what does it mean to these individuals, their families, and our communities as a whole if they're not connected to treatment? We have worked for more than a decade now for decades now to create an interconnected network or a treatment system that is capable of meeting the needs of people all across the state. We do worry that this MOU piece will create barriers to access that treatment and to get people the treatment that they need. But I want to dedicate most of my time this afternoon to the harm reductions piece of this bill. We should note, in context, we have made such tremendous progress in addressing the addiction crisis. Our overdose rates, both fatal and non-fatal, are declining rapidly. Last year we had roughly the number of fatal overdoses in this state was down 1/3 from 2 years prior. We're less than half of where we were at the height in 2017. Our systems are working. No one deserves more credit than our harm reduction programs. No one is delivering more Narcan. Nobody's connecting more people to treatment. Nobody's picking up more needles from the streets than our harm reduction programs. To the extent that we limit their operations, we try to control their messaging, that will just undermine the work that they do. So as was noted earlier, this bill's attempts to provide more local control of these programs, some of that is already in place. Municipalities can already control, for the most part, the location, the hours of operation, that sort of thing. This bill would give local municipalities more control over their messaging. I know the elected officials in our local communities are well-intended, they're well-educated, but most of them, to my knowledge, are not public health professionals. They are not versed in best practice. They're not versed in evidence-based messaging or language or operations. And again, I really worry that any effort to try and sort of control these programs within our borders will really mute their impact and really undermine the progress that we have made. Lastly, I do want to say, I guess bouncing back to the MOU piece very, very quickly, I think we really don't understand the extent of this problem at all. It was, I know that Representative Nagel had asked for numbers, and it was referred to earlier when asked in the Senate. Chief Marr from Manchester cited 5 incidents that he was aware of people being dropped off in Manchester. Of those, I believe 2 of them were from out of state and would not be subject to this RSA. So this is not to say that it's not a problem. It's not to say that the numbers aren't larger than that. It is to say I don't think we understand the extent of this problem in any way, shape, or form. I think this bill would not do what we are intending it to do and would ultimately have unintended consequences that really undermine the progress we've made. And I'm happy to take questions.
Okay, Representative Pelosi.
Thank you, Mr. Chair, and thank you for taking my question. So, according to your understanding of those 5 cases that we know of, like how many of those were against the rules or against the laws, and what current framework would allow an accepting municipality or a victimized person to have some recourse against the situation when person was dumped without services available?
Sure. Thank you for the question, Representative. I will say, a number of the speakers before me today cited different RSAs that already put, that already to some extent restrict that kind of transport. I certainly, so it sounds to me like it certainly is in violation of current statute. It is definitively in violation of best practice and medical ethics and a variety of other things. So I think there are current restrictions in place that may not be adhered to. So maybe there are ways that we can look to strengthen what's in place now. That's a conversation worth having. But I would certainly argue, and Representative McLean, you kind of made the point earlier, I think really what we should be talking about are ways to strengthen our Doorways program so that there's better access to treatment in all different parts of the state, so people don't have to be centralized in one case. This should, our addiction crisis is not a Manchester problem. We can't deal with it like it's a Manchester problem. We need to make sure that the networks are in place all over the state, and I think that there are certainly ways that we can discuss doing that to strengthen what we know to be working already.
Anybody else? Well, it looks like you got off easy, Mr.
There you go.
Berry. So,
Thank you all.
And so I don't think that we have any other pink cards. So with that, I'm going to close the hearing on SB 441, and we are adjourned until 1:30, where we'll be taking up Senate Bill 615, right?
Correct.
Yeah, 615. All right. So we are adjourned.
Yes.
Good afternoon, everyone, and welcome back to the House Committee on Health, Human Services, and Elderly Affairs. We're delighted to welcome back Representative Jim McKay after a bit of an absence. The next bill to be heard this afternoon, the last bill of the day actually, is SB 615 FN. The prime sponsor, Senator Victoria Sullivan from Manchester, is not able to be with us and has asked Representative Polazov, who's a member of our committee, to introduce the bill. So Representative Polazov, please go ahead.
Thank you, Mr. Chair. For the record, Representative Yuri Polozov, Maymark 10, Hooksett and Dunbarton. I'm introducing Senate Bill 615, an act establishing a commission to study the use and regulation of SNAP in New Hampshire. This bill establishes a commission, but my understanding is that sponsors of this bill still would like this committee to do more than just establishing a commission. It was in original form of the bill before it was amended in the Senate. And with that, I will finish my testimony because I was not planning to testify before today, and I will not be taking questions. Thank you.
Thank you, Representative. Next up to speak, Elsie, I believe it is, Cipriani from the New Hampshire Food Bank. Oh, you need to hit the button at the base there. There you go.
Can you hear me? Okay,
We can.
perfect. Good afternoon, Chair McDonald, Vice Chair Mazur, and members of the Health, Human Services, and Elderly Affairs Committee. My name is Elsie Cipriani, and I'm the Executive Director of the New Hampshire Food Bank. Thank you for the opportunity to testify in support of Senate Bill 615 as amended. As the only food bank in our state and a 40-year program of Catholic Charities New Hampshire, also a member of Feeding America, the New Hampshire Food Bank seeks to alleviate food insecurity through our state-wide network of over 400 partner agencies by nourishing our communities through innovative programming. Our Fresh Rescue program recovers fresh, surplus food that is safe and nutritious, but that can no longer be sold by our food sources partners. Our SNAP incentives programs doubles SNAP dollars for produce. Through our Cooking Matters classes, we teach our neighbors how to cook. We support food pantries in expanding nutritious food options too. Our New Hampshire Feeding New Hampshire program helps our agencies purchase locally grown foods. Through the summer meals programs, we provide thousands of healthy meals to children over their summer break. And we gladly help our neighbors submit SNAP applications that accurately reflect their situation. These programs are a means that the New Hampshire Food Bank uses daily to help people move away from food insecurity. In 2025, the New Hampshire Food Bank distributed more than 20 million pounds of food. This is the equivalent of over 24 million meals. Yet, this fell far short of supplementing the need of our neighbors who are experiencing food insecurity. This past November, when the New Hampshire Food Bank served as the SNAP contingency plan for the state during the federal government shutdown, we and our partners distributed more than 136,000 meals across New Hampshire. That was done in only 2 weeks. In addition, our partner agencies have reported a significant increase in the number of people that they are seeking every week, sometimes double, sometimes triple the number that they were seeing in the previous years. And according to Feeding America, 2025 mapped the meal gap 1 in every 9 Granite Staters and 1 in every 7 children in New Hampshire faces food insecurity. This number gets even worse in some areas of New Hampshire. If we go to the North Country, for example, more than 20% of children in these areas are facing food insecurity. Therefore, understanding that without the amendment as it's written, Senate Bill 615 will increase hunger, stigma, and administrative burden without better health outcomes, and understanding that the study commission as written in the amendment of Senate Bill 615 will fully study the fiscal and human impacts of SNAP restriction before taking action. The New Hampshire Food Bank respectfully urges you to adopt Senate Bill 615 as it was amended. Thank you very much for your consideration.
Thank you. Any questions? Yes, Representative Lucas.
Thank you, Mr. Chairman. Thanks for taking my question. I just needed to clarify. You said 1 in 7 children are facing food insecurity, and then you said something about 1 in 4, but I didn't hear.
No, I said that more than 20% of children in some areas face food insecurity. For example, the North Country.
Thank you.
Representative Drew.
Thank you, Mr. Chair. What is your definition of food insecurity?
We use the definition that Feeding America uses. It says that lack of consistent access to food for someone to be able to perform activities as any other individual.
Any other questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, as this comes to us now, it comes to us in the study committee form. Are you, couldn't quite make out your testimony. Are you okay with the study commission?
Yes, we are.
So you're okay?
Yes,
with that?
we are supporting the amendment that was made to Senate Bill 615, which is the commission, the study commission.
All right, thank you.
Thank you.
Other questions? Representative Markell.
Yes, thank you, Mr. Chairman. After looking at the types of representatives who are recommended in this bill to be a member of the commission, is there any group that you think was omitted or should be added to this list of representatives?
I believe the group is very well representative of people working in the food insecurity field in New Hampshire. However, I know that there are going to be other people testifying after me. One of them is New Hampshire Hunger's a representative from New Hampshire Hunger Solutions, Laura Milliken. Yeah. So I'm sure that she can also answer this question.
Okay. Thank you. No further questions.
Anyone else? Any other questions? Seeing none. Thank you.
Thank you very much.
Also signed up to speak is Drew Klein from the Josiah Bartlett Center.
Good afternoon, Mr. Chairman, members of the committee. Thank you for the opportunity to testify. I'm Drew Klein, president of the Josiah Bartlett Center for Public Policy, New Hampshire's free market think tank. Wanted to comment on a couple of points of this bill. Just for clarification here, we have not analyzed the portions of the bill that aren't directly related to the restriction on SNAP benefits. So we just are about to publish a study today on the likely effects of the SNAP benefit restrictions on purchase of soft drinks and candy. So we've analyzed that portion of the bill. And I think given our analysis, it would make sense to continue that portion of the bill to be studied. And we're not advocating for continuing the study on the other portions of the bill. We think we're generally in favor of work requirements and strict oversight of eligibility. But to get to that benefit reductions portion, we just finished an analysis of that, and our analysis, based on publicly available data, suggests that those restrictions on the purchase of candy and soft drinks would produce a pretty significant impact on New Hampshire retailers, depending on how effective those restrictions are at actually reducing consumption. So when we look at it in our model, excuse me, we would look at about $17.8 million reduction in sales of soft drinks and candy if it was actually effective at doing what its intent was, which is preventing SNAP beneficiaries from buying those products. But we're not sure it will actually do that. So when we look at other examples from other states in the past of restrictions on benefits, we see that you would usually calculate about a 30% reduction. So a $3 reduction for every $10 that you actually expect to reduce purchases by. So when you apply that, we're looking at about a $5.3 million reduction in sales of soft drinks and candy at New Hampshire retailers. So somewhere in that range, depending on how effective this law actually is at getting people to stop purchasing those things. Now those numbers do include New Hampshire residents and residents from out of state. So as you all know, we attract a lot of people to cross-border sales in New Hampshire because we have no sales tax. That includes SNAP beneficiaries. So our model looks at those cross-border sales, and we include a factor of how much New Hampshire businesses would lose in cross-border sales. Now, it's important just to note that we only look at candy and soft drink sales in this decline in revenue for New Hampshire retailers. We don't look at what the effects would be if certain percentage of folks from Massachusetts, Vermont, or Maine just stopped coming to New Hampshire altogether or reduced their trips. That would then be a much larger financial impact. So just wanted to apprise you guys of our research on that. We do think it would be a pretty significant hit to New Hampshire retailers. The rest of our study, which I won't get into here, I'm happy to answer questions, and we'll have it posted online later today, suggests that the benefits are probably doubtful, but the costs are real. So that's our take on that portion of the bill. Happy to take questions.
Okay, any questions? Representative Weber.
I'm sorry, I had to step out.
Sure.
Am I right in thinking that that is no longer in the bill?
So it's been converted to a study committee.
Right.
Right. So our analysis on the original bill, which the study committee would study, right? So our testimony today is that it makes sense to take at least that portion and not enact it as law, but actually study it, because our analysis used the best available data we could get. But I think if you had a study commission that was able to get more detailed data from neighboring states, for example, you might be able to drill down on that some more.
So follow up. So so you're supporting the bill as it's been amended, is that right?
On the SNAP portion, on the restriction of sales of candy and soda. Yeah.
Thank you.
Representative McLean.
Yeah, thank you, Mr. Chair. So since it's been converted to a study commission, why not just, study it all so that you can maybe even build on some of the data that you guys have been managed to collect?
Oh, we'd love to study it all. That is a massive undertaking. So given our limited time frame, we're looking at one portion of it that actually hasn't been studied very much.
Okay.
So that's why we focus on that one portion.
Representative Rose.
Thank you, Mr. Chair. So, as I'm sure everyone here is aware, because we've had this testimony over and over, the SNAP program currently does not allow recipients to purchase pre-prepared food, nor does it allow tobacco or alcohol purchases.
Yep.
If we remove those requirements, would that not be a boon to New Hampshire retailers if they could use SNAP for those things?
Well, for one, I think SNAP reasonably restricts those things because two of them are addictive substances that change your behavior. So you don't want SNAP covering that stuff. And then the prepared foods is a long-standing established restriction. So this would be a new restriction that we'd be adding on top of that. And there's a difference between having something that is a restriction in federal law versus one that is a restriction in state. When we do it at the state level, you are going to see those cross-border effects. If this was implemented at the national level, then we wouldn't see these cross-border effects because everybody would be affected the same way.
Other questions? Seeing no other questions. Thank you.
All right, thank you.
Also signed up to speak is Laura Milliken from New Hampshire Hunger Solutions.
Good afternoon, Chairman McDonald and members of the committee. My name is Laura Milliken. I'm the Executive Director of New Hampshire Hunger Solutions. We're a nonpartisan nonprofit organization dedicated to ending food insecurity in New Hampshire and supporting the more than 75,000 Granite Staters who rely on SNAP. I'm here today to testify in support of SB 615 as amended. The Senate made the wise, fiscally responsible decision to convene a study commission to study the bill to ensure that this bill's approach didn't harm our local businesses, increase our SNAP administrative costs, increase our SNAP error rates, or increase the food insecurity in our state. I want to take a moment to review why the original bill mandates were really harmful. First, the original bill would have cut 20 to 25,000 people off the program, including thousands of children who would then lose access to free meals in school. The bill also created a benefit cliff for working families. It would have forced working parents to refuse a raise just to keep their children fed. It also penalized older adults for having modest emergency savings. Second, the bill increased the complexity of administering the SNAP program and massively increased DHHS's administrative costs. Under the changes in the Big Beautiful Bill, New Hampshire now has to pay 75% of all SNAP administrative costs. It used to be that the federal government and the states split the costs 50-50, and now New Hampshire has an additional 25% of the costs to pay. So increasing complexity in the program that increases administrative costs is more costly. Additionally, adding increased complexity to the SNAP program also risks millions in federal penalties next year if it spikes our SNAP error rates. As DHHS has testified, that likely it would. Third, the bill threatened to significantly harm our New Hampshire retailers. The previous speaker gave you lots of information in that regard, but it would force local grocers to police individual grocery items, and many small rural retailers can't afford the software upgrades that would be required to do this. It also would have harmed these businesses by pushing New Hampshire shoppers over the border to avoid these restrictions. It's also vital to remember that for every one meal that a food pantry provides, SNAP provides 9. Our charitable food system, our local pantries, and the food bank simply can't absorb the demand that would result from cutting more people off of SNAP. A commission brings experts and stakeholders to the table: grocers, the Business and Industry Association, medical professionals, and families. It gives us a time to research the economic impacts and the effects on the error rate and find what actually impacts health and program integrity. I urge the committee to support the amended version of SB 615. Thank you. I'm happy to take questions.
Thank you. Any questions? Wow. Okay, thank you.
Thank you. Please.
You just made the clerk very happy. Also signed up to speak is Ray Burke from New Hampshire Legal Assistance.
Good afternoon, Mr. Chairman and members of the committee. My name is Ray Burke, and I'm a staff attorney at New Hampshire Legal Assistance. We're also a nonpartisan, nonprofit law firm in New Hampshire. We serve Granite Staters, low-income Granite Staters throughout the state in a variety of civil legal issues. And one of our practice area includes representing SNAP applicants and recipients who are facing issues accessing the program. We also are here today in support of the current version of the bill as amended to study these issues. I'll take kind of sort of, I guess, the opposite approach as the Josiah Bartlett Center. I'm going to focus my comments on the other parts of the bill, not the food choice portion that you've just heard about. Our concerns with the original version of the bill is that those other provisions would actually have an unintended consequence of increasing our payment error rate. And I just wanted to paint a little bit of the context of why we think it's important to study these issues before we move ahead with changes. New Hampshire, the New Hampshire Department of Health and Human Services has actually been doing a really good job bringing down the payment error rate. The most recent available data is from fiscal year 2022 to fiscal year 2024. The payment error rate came down from 12.34 to 7.57. So the department is doing things right. That's a significant decrease. And over that time, we expanded broad-based categorical eligibility, which this original version of the bill would have eliminated. And we also made changes to how we administer and determine the certification periods for SNAP recipients, which we think are two important policies that should continue. And so we think that given the new importance of the payment error rate under the federal law as it is now under HR 1, it's important to identify what the root causes are, as the department has been doing, and continue to support the department in its effort to address those root causes. And we think the original version of this bill didn't address those root causes, and that's part of why we think it risked increasing the payment error rate, and then would cause us to have to come up with more money as a state for the program. We're actually doing really well when you look across the country. Our payment error rate at 7.57 is well below the national average. Even though we need to work harder to get it down, given the federal law, since it's above 6%, we think the department is in a good position. And so right now, we think one of the biggest concerns is the department having overburdened staff. We think the biggest way to support the department and to help bring down that payment error rate is to support them in filling those vacancies so that they have sufficient staff to implement the program and process the rules that have gone into effect under HR 1. With that, I'm happy to take any questions.
Thank you. Any questions? Representative Lucas.
Thank you, Mr. Chair. Just a quick one. Which fiscal year is that 6% error rate expected to be reached?
So my understanding is that states have an option. They can either use the error rate from this current fiscal rate that we're in, which the error rate hasn't come out yet, it's still being calculated, or they can use the error rate from the next fiscal year. But whichever one they choose, it will apply to 2028 is when the state would have to. You can ask the department to clarify me if I'm wrong about that, but that's my understanding. And then I think after that, it is a 3-year sort of lag period. So whatever, following that choice, the fiscal year 2027 error rate will impact, I believe, fiscal year 2030, if I have it correct.
Any other questions? Saying none. Okay, thank you.
Thank you.
No one else has signed up to testify on Senate Bill 615 FN. Does anyone else wish to testify? Okay. Well, with that, I'm going to close the public hearing on SB 615 FN. That concludes the hearings that we had scheduled for today. We will be meeting an executive session next Wednesday, beginning at 10 a.m. for the purposes of voting on the Senate bills we've received. With that, we are adjourned.